I welcome all of you for today's CME on Pediatric Neuroradiology. As we are, the year is passing now, we will go to the subspecialty CMEs henceforth mostly because only hematology is remained now, and for that purpose, today's CME is organized in that view as a pediatric neuroradiology. So today's speaker are Dr. Hirekeru sir, Dr. Sri Ganesh Patil, Dr. Sahil Savaskar, Dr. Nakate sir. I welcome all of the speakers for today's CME. I welcome Dr. Abhijit Jagtap, who is working as an in charge in a health department at the university. He has actually helped a lot in our research of obesity, which was conducted by me in the last few months. So his department of statistics, they have helped us in a way to make the results. So I welcome him also. And 1200 students they are examined. They have given the questionnaires of 15 questions about the obesity knowledge. And basically, initially, I have conducted lectures on obesity. I have imparted some knowledge to them, and their understanding and whatever the basic knowledge they have answered these 15 questions. So 1200 students they have submitted their questionnaires, and these are statistically examined by Dr. Abhijit sir and his team. So I very much thank from Solapur IIP for doing this for us. Without wasting much time, I request Dr. Hirekeru sir to proceed further. Thank you.
Especially in front of our own members, our own people, and especially in front of sir, our teacher, Dr. Kasniwal sir. So it is really a moment of pride for me today. One lights of we had actually originally chosen this topic because we tend to follow the reports, what is written, actually typed on the paper. Hardly do we go and see on the console actually what the hemorrhage looks like, what the infarct looks like, what brain edema looks like. How many times we have seen that our patient is unconscious, he is not moving at all, on ventilator, and the MRI brain or CT scan is normal. How many times? Many times. Many times our patient is up and about in the ward and the report says that it is brain edema. Cerebral edema is a clinical diagnosis, but it is always forgotten, and then we start giving treatment to this child in the form of mannitol or 3%. So that is the time when I was actually surprised why this is happening. This was happening because we were unaware of what edema looks like, what a hemorrhage looks like on CT or MRI. So that is the reason when Dr. Anna Sahib asked me what to take, I said this is and during those days I was having this problem. So immediately I told him spontaneously that this is what we should be doing. Once our newborn came to me, patient was absolutely alright, and I said it is nothing, and then the patient showed me the report that there is an intracranial bleed, and they were very much about. They didn't show me that way. So after examination they showed me the report, and I saw the report. Yes, it was written. But by that time I had started reading a little bit, and the sequence that is needed for to diagnose hemorrhage is a susceptibility weighted image (SWI), and that itself was not taken. When I contacted the radiologist, he said he agreed, yes, that he had not taken this, but on a T2 image he found that it was probably a hemorrhage, and clinical scenario was something like that. So he asked me to send the patient back and he would do this thing. But the patients were very anxious about all that. So that was the reason I told him that yes, we should be doing this CME. Anna proposed that we should be doing ultrasound also in this CME because in the NICU it is not possible to send this patient for MRI or a CT scan. Introduction and anatomy and how the normal brain looks like. This will be followed in the second part for certain pathological conditions. So why cranial ultrasound? Cranial ultrasound because of these obvious reasons. That is because it is rapid, you need not have to shift the patient, it is non-invasive, there is no sedation needed, it is low cost, and there are no agonizing radiation. You can do as many times as you want. And you can selectively do as many times as you want. You don't need to every time spend 15 minutes, 20 minutes. In 1 minute also you can see, you want to scan a hemorrhage, you know where the hemorrhage is going to be from previous scans, and you can concentrate on that. Where do we apply this? Screening for intracranial bleeding is sometimes may present with the reduced activity, sometimes may be asymptomatic also. Screening of periventricular leukomalacia. Many times you find the report PVI grade 1. How many times you have seen this PVI grade 1? Many times. So this is the usual report. But does it mean anything? That is what we see. Diagnosis and follow-up of a case of hydrocephalus. Patient has hydrocephalus, but is it only ventriculomegaly or is it hydrocephalus? Is it associated with increase in pressure or it is just an increase in the size of the ventricles? That we will know only by following up to follow-up scans. Follow up patient of VP shunt for its complications. We have done a VP shunt and then suppose that it is blocked. Then how do you know? Unless the pressure in the brain increases, which leads to deterioration of consciousness or seizures, only then you will come to know, okay, now this patient has got obstruction of the catheter. But mind you that just because AF is open, patient doesn't have raised ICT, it is not like that. Even with open AF, patients will be having a raised ICT. Follow-up of case of CNS infections. Now this is very tricky thing. Many times these patients they will have cerebral edema, they might land in abscesses, they might have, because of the blockage of the cerebral CSF pathway, they might be having a communicating or a non-communicating hydrocephalus. Patients of meningomyelocele has been operated, and we all well known that once you operate the meningomyelocele, there are chances that the patient will be having hydrocephalus. And finally, color Doppler to distinguish between a vascular and non-vascular malformation. Now, how do we interrogate the neuroradiology? The commonest one is the anterior frontal lobe. This is the easiest one. There are other ways also, and this is done in a salivary plane and coronal. And one should try to get symmetric images and match the symmetric. Even on the report, you should see whether the images are symmetrical or not. Little bit of asymmetry will throw you out of the picture, and you might say that there is some anomaly on one side of the other. The other views are the mastoid and the posterior frontal lobe, which I will not be doing here. I am personally not doing it very much because I didn't find it very time saving. But it is important for certain conditions like posterior fossa hemorrhage and evaluation of hemorrhage in the occipital horn. Now, the basics of radiology is totally in the anatomy. Radiologists are the persons who, after the MBBS, are the best people who know the anatomy of all organs from head to foot. Because that is their basic foundation. So, I will begin with this. Because we are not used to seeing the brain, study brain at all after the first year or the third year. So that is the reason I am going through very basics. So here on the lateral surface of the brain, we have the frontal lobe, which is separated by from the central sulcus or the rhodalian sulcus, and posterior to that is the parietal lobe. Then is the parieto-occipital fissure. This is the parieto-occipital fissure, and then we have the occipital lobe. We have the temporal lobe here, and the lateral fissure of the ciliary sulcus, cerebral fissure. So this is the basic thing about them. So when we are saying that there is a parietal bleed or there is a frontal bleed, we should immediately know where this is occurring. Then there is an interhemispheric fissure. In between the two hemispheres is an interhemispheric fissure, and again this is the central sulcus and the parieto-occipital sulcus. Now coming to the medial aspect. But here it appears to be complicated. But here also we have the frontal lobe, we have the parietal lobe, and we have the occipital lobe. In addition to that, in the center we have the corpus callosum. The corpus callosum are interhemispheric fibers. So they are white fibers, the corpus callosum. And it's the hypothalamic region. This is the temporal, mid-brain, pons, medulla, and finally at the bottom is the cerebellum. So these are the basic things. In addition to that, on the basic surface, I will be telling you two important structures. It is the caudate nucleus and the thalamus. You see the relationship between the caudate nucleus and the thalamus, and they are separated by some other structure. They are not continuous. This I have shown red for certain reasons which I will be telling you later on, and this is the caudothalamic group. It's a very important landmark, neuroradiology, sagittal, brain scanning. Okay, so corpus callosum, caudate nucleus, thalamus, the caudothalamic. The rest all we are knowing. These are the fibers of the corpus callosum that run from right to left or left to right. And this is what the corpus callosum on a sagittal. So this is the shape of the corpus callosum. This part is called the rostrum, genu, body, isthmus and the splenium. There are certain conditions where only the splenium will be affected. As Dr. Srivas will be telling you later on, in certain conditions, only splenium. There are certain conditions in the malformations for example, partial congenesis of the corpus callosum where only the genu will be affected or the isthmus will be affected. So that is the reason I am showing you all this. And finally the ventricles of the brain. As you all know, ventricle not much to tell, but I am showing this picture just to show its relationship to the rest of the brain. This is the lateral ventricle, third ventricle, the central gap in between. This is for the interthalamic fibers. So have fibers from one thalamus, right thalamus to the left thalamus will go through this. So that means there is a gap. The aqueduct of Sylvius and the fourth ventricle. Okay, so far so good. All understood up till now, nothing hi-fi right now. A little bit will go ahead. Now the internal capsule. So we saw the lobes of the brain, we saw the lateral surface, we saw the medial surface, and now the ventricles of the brain, now internal capsule. You all know the position of the internal capsule, that this is an L-shaped structure. On the lateral side of it, there is a globus pallidus internal. Beyond that is the globus, still lateral is the globus pallidus externa, still lateral to that is the putamen. On the medial side is the caudate nucleus, and lower down at the posterior region on the medial side is the thalamus. Okay? Understood? Can I go ahead? Now coming to sisters. I am telling you about the structures that we are used to see in the reports only. I am not telling you any details. Now sisters. Now what is a sister? You all know that the arachnoid matter and the pia matter are closely attached to the surface of the brain. So it is called the pia arachnoid. So they are not separable. As I said, the neural matter can be separated, the pia arachnoid cannot be separated. Except in certain regions. The red one is the pia matter and this is the arachnoid matter. Blue one is the arachnoid matter. And you will see that only in certain regions they are separated. These regions are called the cisterns. There are the three important cisterns, that is the cisterna interpedicularis, cisterna pontis, and cisterna cerebellomedullaris or the cisterna magna. Of this, on the ultrasound, the cisterna magna is very easily seen. And this is the only important cistern that you would like to see on the ultrasound. Then coming to the choroid plexus. You all know that CSF is produced in the choroid plexus and it is in the brain. So, but where exactly in the brain? So here it is. At the floor of the lateral ventricle. This is the lateral ventricle. This is the frontal horn, the occipital horn, and the temporal horn. So on the floor of the lateral ventricle, it winds around when this passes through the foramen of Monro into the roof of the third ventricle. This is its location. So this is important again for us to interpret the report on the ultrasound. And this is the only thing that we would like to know about the choroid plexus, nothing much. Part of it does extend into the temporal horn as well. Then germinal matrix. What is this germinal matrix? Germinal matrix is the lining of ventricle which is present all over the ventricle. And they are the source It is highly cellular and highly vascular because it contains cells which are rapidly dividing, and these are the cells that are going to give rise to the brain parenchyma proper. As they start multiplying from the surface of the ventricle, they will start going up to the cerebral cortex. But it will regress gradually as the gestation advances. And by 24 weeks, it is present only over the head and body of the caudate nucleus. It is not visualized on ultrasound. But when there is a problem, there is a germinal matrix bleed, it will present which occurs in the preterm, it is visualized by ultrasound as well, ultrasound in the caudothalamic groove. This is another important landmark, the caudothalamic groove. Now, what is this caudothalamic groove? This is the gap, groove between the caudate nucleus, this is the lateral surface, caudate nucleus and the thalamus. In between that is what is called the caudothalamic. This is the caudate nucleus, this is the thalamus. This is the caudothalamic. One here light से बंद करो. Now, how is an image formed by an ultrasound? This was the anatomy. Now, how is an image formed? The ultrasound beam will be collected inside the body. Part of the beam will be absorbed by the structures. Part of it will be reflected back to the machine, and part of it will pass through and through. If there is fluid, all the ways will pass through the structure, and then we get the image is formed by the reflected waves on the screen by the software. And what are the three types of structures that we see? Anechoic, that is total black, hypoechogenic, total white, and in between the black and white, different shades of grey, that is called the grey scale. So, what are the structures that are fluid? Fluid is black in color, this is the amniotic. This is just to show what is black and what is white. Hyperechogenic, white is hyperechogenic. For example, the bone, the skull bones, the spine is completely white. So, bone, air, fat, and tough structures like the diaphragm and the pleura, they are white, extremely white in color. And depending on the density of the organ, structure of the organ, there will be different shades of the. Now, how do we image? We image in the sagittal plane as well as in the coronal plane. So, let us go with the simplest one, that is the sagittal plane. So, here the transducer that we use is a high frequency transducer, 70 milliwatt in a small footprint. We don't want a big one, big surface of the ultrasound probe. We want a small footprint because that is the small area that is available to us to scan. From here, the way ultrasound waves will fan out. And then the beam is swept from medial to lateral. The beam is swept from medial to lateral. How? So this A is the central structure, central beam, and then we fan the beam on the left side as well as on the right side. Now coming to the sagittal section, that is the A section, which is dead central. And what are the structures that we are going to see here? We saw in the medial surface, we are going to see the lobes of the brain, frontal lobe, parietal lobe, occipital lobe with the parieto-occipital fissure. Then this is the corpus callosum. You can appreciate this corpus callosum. Above that is the cingulate gyrus and the cingulate sulcus. Then exactly below the corpus callosum is a structure which is black in color, which is fluid. It is called the cavum septum pellucidum. The two hemispheres of the brain, in between them there is a meninges. And these meninges, in between the meninges is a fluid. As the gestational advances and the child grows, this fluid is resorbed. So if you see a preterm, you will see a lot of fluid in this region. It is called the cavum septum pellucidum. In a newborn, you will see a little bit less, and in the older child, you will not see at all because this fluid is absorbed. But cavum septum pellucidum is the fluid in between the two cerebral hemispheres. Then we have the third ventricle. We have the aqueduct of Sylvius and the fourth ventricle. And in the floor of the third ventricle and the roof of the fourth ventricle, we have the choroid plexus. The cerebellum and cerebellum is separated by the tentorium. This is a tough structure, so it is going to be which in color? White in color. The parieto-occipital fissure, mid brainstem, midbrain, pons, and mid. And finally, at the bottom there is the cerebellum, but it is the central part of the cerebellum that is called the nervus. So this is the sonologic image. So here we will see the frontal lobe, parietal lobe, and the occipital lobe. Parieto-occipital fissure. K1 is black. Can you appreciate this black structure? This is a full term child, so you are not going to see it very well. So this is the K1 septum pellucidum. It is seen also posteriorly. Can you see this space posteriorly? So gradually as the age advances, the central part regresses and the anterior and posterior part remains. The anterior part is called as K1 septum pellucidum and the posterior part is called K1 Burke. The choroid plexus. Now the third ventricle. This is the third ventricle. And I had shown you there is a central gap in the third ventricle that we are not seeing. Okay, just remember this and when we are going to see it. So we are not seeing that. We are not seeing the interthalamic thalamic connections. The fourth ventricle and the aquila of the seamless. Brainstem, midbrain, pons, medulla. This is the vermis, and this black thing you can see. What is this? I told you, cisterna magna. It is very small. Less than 10 mm is normal. Now this was a dead sagittal image. Now we go to little bit lateral. So 10-degree lateral angulation. With a transducer space, it is angulated little bit by 10 degrees and we get the parasagittal image. Now here what we will see the same structures, but it will be a different, little bit difference will be there. So we have frontal lobe, parietal lobe, occipital and body of the lateral ventricle. Now this is a trigone. This is another new structure, structure now, and the frontal horn, the occipital horn and the temporal horn, they meet together. And when they meet together, this is the area where they meet, and that area is called the trigone because that is a meeting point of the frontal horn. This is the frontal horn will be here. Now this is the frontal horn. The temporal horn is usually we will not see, it is very small, and the occipital horn. And here you can see some. This is the area where the choroid plexus has got maximum mass, and that is called the glomus of the choroid plexus. The glomus of the choroid plexus. Then we have this caudate nucleus. I have told you the caudate nucleus and the thalamus, and in between that there is a groove. Here you are seeing little bit white structure, but normally it will not be appreciated. I put this here only to differentiate between the caudate nucleus and the thalamus. This is the caudothalamic groove. This you are going to see in the parasagittal image. You are not going to see that in the dead sagittal image. And the caudothalamic. And the importance of caudothalamic groove is that whenever there is a germinal matrix bleed, it will begin at the caudothalamic groove because of presence of the very vascular germinal matrix. And finally the cerebellum. This is the caudate nucleus, this is the thalamus, and in between that, this is the caudothalamic. Then coming to the still going more laterally, the periphery of the ventricles. Now this is a 10-degree angulation, now we will go still. And what we see is the lateral cerebral hemisphere. And here can you see these fibers? White lines, are you able to appreciate? Yes. These white lines is called the peritrigonal blush. Now, what are these white fibers? These fibers are nothing but the corona radiata coming down like this, and your ultrasound beam is going like this. So, ultrasound beam is cutting the corona radiata perpendicularly and it is casting this. Now, this is the peritrigonal blush. Now, compare this peritrigonal blush to the choroid plexus. Compare this peritrigonal blush to the choroid plexus. What do you find? Which one is more echogenic, the choroid plexus or the peritrigonal blush? Yes. The choroid plexus. So this is classified as the grade 1 PVL, which is normal. So that is why it should not be reported in first 7 days in a preterm child because it is a normal findings. And when you write PVL, people think that it is something very abnormal happening inside the. When the echogenicity is equal, it is labeled as like grade 2. And when the peritrigonal blush is more echogenic, it is labeled as grade 3. Now coming to the coronal image. Now transverse here is placed transversely, and then how are we going to image? We are going to cut the brain in a coronal section from anterior to posterior. Anterior to posterior. And it is mandatory to give you 6 standard images. 6 standard images plus 3 plus 5 sagittal images, because one mid sagittal and two parasagittal on each side. So 5 plus 6, 11 images you should be able to see on a with the ring. Here you find that here there is nothing, there is no frontal horn in A. When you start cutting the B, there will be the frontal horn will be there, the caudate nucleus will be there, but there will be no thalamus. Now, as you go still posterior, now you will see the third ventricles. You will see the thalamus. You might see the temporal horn as well, and then you are going to see the midbrain pons and mid structures in the medulla. You go still posteriorly. Now you will cut all the structures plus the fourth ventricle. You go still behind. You will be cutting the cerebellum, and you go still behind. You will see the area of the triangle. E is actually triangle, and here there will be. It is also in the triangle, but forehead plexus will not be seen. So these are the 6 sections that you are going to see. So if you want to see a thalamic bleed, then you are going to see, you will be able to see this not in the B but in C. If you want to see the dilatation of frontal horn, then you are not going to see it in A, neither in F. You have to see in B or C or little bit in D. If there is a forehead plexus bleed in the glomus, then you are going to see it in the E. If you want to see the cerebellar bleed, then you are going to see only in one image, D or E. You will not be able to see any other image. So this is the importance of knowing the anatomy. Now let us briefly go. So this is the revision to see what structures we are seeing. So frontal lobe, parietal lobe, occipital lobe, cerebellum, midline, pons, middle. In the midline there is a caudate nucleus, the corpus callosum. Here is the caudate nucleus, the thalamus, and the temporal. So just to further, I want to recognize things. Now this is the section that is anterior to the frontal horn. The first image, and here you will see that there is nothing here. This is just the frontal. So just will forget this. Now through the frontal horn, what we are going to see? We will see the corpus callosum. We will see the body of the corpus callosum. We will see some ventricles as well. This is the occipital horn. In the midline, we are going to see the cavum, septum pellucidum. Corpus callosum we will be able to see. This is the temporal lobe. This is the caudate nucleus. We are not going to see the putamen or the thalamus. Internal capsule, yes, we are going to see the internal capsule as well, and lateral to internal capsule. This area will be the putamen. So any bleed in the putamen will be seen in this region. And this is the Y-shaped silver fissure. So this is the interhemispheric fissure. This is the corpus callosum. This is the frontal horn. This is the cavum, septum pellucidum. This area is the caudate nucleus. Beyond that will be the putamen. And this is the Y-shaped silver fissure. Now coming to the level of the midbrain. See in the third what structures we are going to see. So we are going to see again the corpus callosum, the ventricles as well. But there are few additional structures that we are going to see in the third ventricle. Now we are coming to the third ventricle. Now this is the third ventricle. In black structure you can see this is the third ventricle. And now you will be able to see thalamus more clearly in this region. And we have globus pallidus and putamen. The area lateral to the putamen is called the central semioid. Many times we see this word in the report that this is this area just lateral to the globus pallidus and putamen. And then we have the silver fissure. So interhemispheric fissure, corpus callosum, these are the frontal horn. This is the third ventricle. See, third ventricle you are not able to see. It is just a slit like normal third ventricle is just very. It is anterior posterior. It has got some dimensions, and superior inferior also got dimensions, but it is very, very thin. Beyond 2 mm is of the ventricle is around 5 mm. Then through the cerebellum, the fourth one, through the cerebellum. The extra what we are going to see, we are going to see the choroid plexus. Actually, choroid plexus goes from the floor of the third ventricle into the roof of the fourth ventricle. Vermis is echogenic. You can see here white, round thing, but the hemispheres are not echogenic. They are hypoechoic as compared to the vermis. So if there is a cerebellar bleed, you are going to see in the vermis, in the cerebellar hemisphere, and hemorrhage is always white in color on echocardiogram. Temporal horns are also very thin. Normally they are not seen in this section. If you are able to see the temporal horns in this region, If you are able to see the temporal horn, that means the patient has aerospace. If you are seeing the third ventricle which is more than 3 mm, then there is definitely aerospace. So these are the findings here. As I told you that the choroid plexus runs from the floor of the third ventricle into the roof of the fourth ventricle, and this is that particular cut where this white thing is the choroid plexus on two sides, which is coming from both the lateral ventricles and going through the foramen Monroe into the fourth ventricle, third ventricle. So 1 dot, 2 dot, and 3 dots. These are the 3 dots where see this is called the 3 dot sign on the ultrasound. This is a normal finding. This should not be mistaken for a hemorrhage. Many times I have seen reports where hemorrhage and this is what they have labeled, but this is not hemorrhage. This is a normal finding of the choroid plexus. Through the trigone, what specialty of the trigone? Trigone is in the occipital horn. It is the glomus of the choroid plexus that we are seeing. And then we see the other thing, the occipital cortex and the cerebellum. Now the glomus of the choroid plexus is a very dense structure. It is so dense that the CSF is displaced away from it. So that is why in this section, this is the glomus. This is a symmetrical image that I could acquire. And around that there is no black structure. Little bit it is here, but there is no black structure. So this is a normal finding. If you are able to see, black means fluid. If you are able to see fluid around this globus, that means definitely there is hydrocephalus. So definite hydrocephalus is what? Presence of 2-3 findings I have told you. Presence of the occipital horns. More than 3 mm of third ventricle. And in the coronal posteriormost coronal section, if you find that there is a black shadow around the glomus, then this is definitely hydrocephalus. So hydrocephalus is not at all difficult to find. And finally, posterior to the occipital horn, just there is the occipital horn here and the cerebellum. So this was all about the anatomy. I have covered only those structures that we see on the report. I have not gone into detail. More details maybe CT and MRI, because many structures are seen in that, so they will be covering that. But here only simple structures I have seen. Thanks for patiently listening. So any anatomical
Many times there is a report that cerebellar vermis is not united.
Cerebellum vermis, yes. Sir, I had actually omitted that because the talk would go on long. So, the cerebellum vermis not united, not present, you want to see, not seen. There is no question of cerebellum vermis being united. You might have seen reports that cerebellum vermis not seen. Am I right, sir?
Cerebellar vermis, normally both the lobes of the cerebellum should unite in the midline.
Okay.
They are not united.
They are not united. So that is what I am coming to. So that is an absent cerebellar vermis. That is actually I have omitted that slide. So that is a developmental. I have omitted the topic of development of the brain in the newborn. So cerebellar vermis is normally not seen in prematures, and you can make an erroneous diagnosis of an absent cerebellar vermis. That is what we are saying, that the cerebellar hemispheres are not united because the gap in the middle is not seen. So this will be usually seen in patients of preterms where cerebellar vermis is not seen. It is seen later on as the gestation passes. So if it is seen in a full-term child, then it is an absence of cerebellar vermis. Then it is an abnormal child.
What is the significance? If it is not seen.
So absent cerebellar vermis itself, if it is a finding alone present, then it may not have any significance. But many times it is associated with other findings, other anomalies of the brain, and then it is a significant finding.
Thank you, sir, for clearing the doubts about what we see. Actually, the printed report is given of sonography. We just try to read the reports and see the what are clinical things. Thank you for giving the clinical orientation and anatomical orientation of the cranium. Now I request further for Dr. Sri Ganesh sir to talk on the CT scan, basics of the scan and its implication in pediatrics.
You want to clear sir's doubt?
Rightly told, preterm it was not seen. It is a normal thing. There are genetic conditions, many genetic conditions like cerebellar anatomy and this thing. In that case, it can be the significant. That was associated with the other anomalies also. Yes, we will discuss in the MRI also, sir. Okay.
Good morning, all. Thank you, Solapur IIP, for giving me this opportunity. Thank you, all respected seniors, for being here for today's session. So, already we have a wonderful session on the sonoanatomy of the brain. And now we are moving to the next talk of the today's program, that is basics of the city brain and its role in the pediatric neurological emergency. The interesting thing about the CT and MRI thing is that everybody wants to know about the CT brain and the MRI brain, but afraid to ask. Why this topic was here? Why we want to learn about the basics of the CT brain? So we know that in emergency, as the patient comes in the emergency in the night, many of the hospitals will not have the facility of the MRI. The patient is not the hemodynamically stable. So in emergency cases, we have to rely on the CT brain for evaluating the intracranial emergencies like stroke, trauma, subarachnoid hemorrhage, intracranial hemorrhage. Most of the pediatrician has very limited experience about the CT interpretation. And as I already told, the pediatrician must interpret the basics of the CT brain. The pediatrician must know about the hydrocephalus, must know about the midline shape, must know about the herniation. Because the patient will come in the night, the patient is the serious, hemodynamically not stable. He will send the patient for the CT brain. Patient will come back with the CT films and the radiologist will say we will give the report in the tomorrow morning. So in such cases, pediatrician must be initially interpret about the emergencies on the CT scan brain, basic anatomy of the CT brain. He should find out the hydrocephalus, midline shape, herniation, rise CT, and should act promptly on the. So that's why this topic was included. What will be the learning objectives for the today's presentation? We will start with the basics of the CT brain. We will see the neuroanatomy of the CT brain in the different planes, in the different sections. Then we will see how to read the CT brain in the 5 basic steps. And I will assure that at the end of the session, you will at least able to read the CT brain in your day-to-day practice in the emergency by simple 5 steps. And lastly, role of the CT brain in the pediatric emergency. So starting with the basic principles of the CT brain. So CT brain was discovered by the Sir Godfrey Hounsfield in the 1972 and he got the Nobel Prize for the same in 1970. What are the advantages of the CT brain over the MRI? So it is easy availability. As I already told, most of the hospital will not have the MRI availability. CT scan is the easily available. It is fast. It is the investigation of choice for the hemorrhage, calcification, and disadvantages are the radiation exposure. And we will not get the proper parenchymal visualization on the CT brain. So I will say that CT brain is as equivalent at the sonography. Sonography also, as sir was already told, hemorrhages, calcification we can detect on the CT scan, USG also. So use the CT brain very judiciously because it is the high radiation. Unless and unless it is indicated in hemodynamically unstable patient, we are suspecting the hemorrhage, we are suspecting the calcification, then go with the CT brain. Because it will have the high radiation, most of us will think about the cost. It is low cost, then we will do this, patient is not affordable. But I think it is not the issue. We are spending 2,000 rupees for the CT brain and the MRI will come in the 5,000. So it is not a big issue. That cost is not the big issue. So use the CT brain judiciously. Basics of the CT brain, very simple basic principle. Different tissues absorb the X-rays by the different degrees. Like air will absorb the X-rays by the different degrees. Tissues will absorb the X-rays by the different degrees. And always describe the findings on the CT brain in terms of the density. So whether it is isodense, whether it is hypodense, or whether it is hyperdense. And what is the reference density? Reference density is the brain parenchyma. So anything that is brighter than the brain parenchyma is the hyperdense, like our bone. And anything that is darker than the brain parenchyma is the hypodense, like CSF and the fluid. So always describe the CT findings in terms of the density. In MRI, Sai will cover that. We will describe in the terms of intensities. It is either hyper intensities or hypo intensities. But in the CT brain, it is in the terms of the densities. Either your specific lesion is isodense like brain parenchyma, hyperdense like bone, or hypodense like the CSF. So this is the basic principle by describing the CT brain. Now we will move to the normal neuroanatomy that's seen on the CT scan here. We are not the radiologist. We are just thinking about the basics of the CT brain. We were just thinking about the usefulness of the CT brain in our pediatric emergency. When the patient comes in the night, when the patient is hemodynamically unstable, we have to act in the emergency. So cuts will be taken at the 3 different sections. That is axial section, that will be the horizontal section, and that most of the films we observe henceforth, the most of the CT films will be getting only in the axial sections. Okay. For sagittal coronal plane, that will be the vertical plane like this coronal plane. This is useful for the pituitary gland and the sella. While the sagittal section are rarely used in the CT brain, they are most commonly used in the MRI. So henceforth, you will observe what are the plates you are getting in the CT films. In 90%, 95% or in the always, they are always in the axial sections. So we will, as we are seeing the basics, we will only see the neuroanatomy of the CT brain in the axial section. So this is axial section, this is coronal section, and this is sagittal section. So to make it easy or to make it better understanding, I have made some mnemonic. So this is how you will get the CT films. Okay, here is the patient's ID, and we will make the mnemonic. We will read it as a layman. That what will be in the first 2 rows. That is, we will get a picture like a cross. Let's see, this is a cross. Okay, this is the first level. We are going, patient is going into machine like this, and the axial section will be taken from the base towards the, and we will see the 6 sections. Okay, so the first will be, we will look like a picture like a cross. I will see in the detail. I will just show in the this yellow circle. That is, this is a cross-like picture. As we move further, as we move up, we will get the picture like a star. Okay, I will show you that the picture like a star. Further up, we will get the picture like a happy face. I think this is will be the happy face. I will show you the detail. Further up, we will see the picture like a sad man. This is the picture like a sad man. Further up, we will get the picture like a 2 worms. As we are coming at this session up and up, we will get the picture like a 2 worms, and we will see the neuroanatomy with relation to this picture to memorize it or to make it very simple. And lastly, when come at the top, we will get the picture like a beans. So this will be the picture like a bean. So let's start the first section, that is at the base of the brain. And as I already told, we will get the picture like a cross. Okay, so see, this is a cross. Okay, and what is obviously seen to do is, these are cerebral hemispheres. In the cross section, try to identify the cerebral hemispheres. Then this is the brainstem. Okay, and these are the temporal lobe. So at the first 2 rows, there we will get the picture like a cross, and there we have to identify the cerebellum. Then we have to identify the brainstem. We will come to the interpretation later. We are just seeing the neuroanatomy here. Then this is the brainstem, and this is the temporal lobe. As we go up, we will get the picture like a star. Okay, so we have come to the up at this level. From the base, we come to the up, and we will get the picture like a star. Not exactly like a star, but if you think of a star, then you will also come to know, yes, it is like a star. Okay, and what the anatomical structures we are seeing here, I am just showing the only basic structures, not going to the deep that are useful in our the emergency. As we are coming up, we are seeing the pons and the medulla, again temporal lobe, and here the 4th ventricle. Okay, cerebellum is also visible, cerebellar hemisphere is also visible in this section, and this is the cerebellar tentorium, which will separate the supracellular regions from the cerebellum region. So this is the second section that will look like a star. Consider this is as a star, and look for the anatomy at this section as a cerebellum, then pons and medulla, then 4th ventricle, and the temporal lobes. As we go up, then we will get the face like a happy man face. Just think, this is the happy man face in the diagrammatic presentation, and this is our actually CT scan, and this is the happy man face. Okay, so as we are coming up, just consider it as a happy man face and try to identify the neuroanatomy. On the happy man face, these 2 structures are the thalamus, then these are basal ganglia. Then again, as we are coming up, now we will see the occipital lobes and the frontal lobe. So happy man face is the looking for the ventricles also. Till now, we have not seen the ventricles. So here in happy man phase, we will see the ventricles also. So we are coming up, further up, and here we will see the fourth level, that is the sad man phase. I see in this diagram. This is the, now we see the cross, we see the star, we see the happy man phase, and now we are coming the little bit up also, that is the sad man like face image we will get in this section, and this will be the useful at the level of this. We will see the occipital horns of the lateral ventricles along with the frontal horns of the lateral ventricles. Last slide I was forgot to tell, in this image, that is the happy man phase, this is the most common image, that at this level we have to see for the deep intraparenchymal hemorrhages and the sometimes hydrocephalus, because the ventricles we will see at this level, happy phase level. So we will able to identify the hydrocephalus as this level. So at the sad man phase, we will look for the occipital horns, and also we will look for the temporal horns of the face. Further up, it will look like a two worms. Okay, it will the fifth level on the axial side. It will look like a two worms. I am talking about this image. Okay, and what is the importance of what will the neuroanatomical structure? We will look at this image, or at this level. We will look for the occipital horns of the lateral ventricles. Okay, and what is the importance of the occipital horns of the lateral ventricle? It is the most dependent part of the ventricle because of the gravity, and even with the soft hemorrhage, because of the gravity, it will accumulate in the occipital horns, and that is why even the small hemorrhage can be depicted on the occipital horns. And for that, we have to see this type of image where it will looks like a two worms, and finally at the top we will look like a beams. So we are now here. We have come out the top of the CT scan, and it look like a beam shape. And which structures, important structures in the emergency or in a common structure, we will look at this level is this is the flux cerebri connecting the two cerebral hemispheres. We have to look here the gray and white matter differentiation. We have to look here the symmetry of the two cerebral hemispheres. So I think this is for the basic neuroanatomy on the CT scan. Look at the 6 different levels. First is at the base, it will look like a cross. Look for the cerebellum, look for the brainstem. Second, when you go up, it will be like a cross, it will be like a star shape. You look at that level, look for the pons. Further up, happy phase, ventricles will be able to see at this level. We will look for the thalamus, basal ganglia at this level. Then sad phase, it will be look for the occipital horns. And then further up, two worm stage, it will be look for the occipital horns, lateral ventricles, and lastly, bean shaped. This is like it look like a bean shaped. Flux cerebri and the two cerebral hemisphere, symmetry, then gray and white matter differentiation. So this is the basic of the neuroanatomy on the CT brain. So now the most important part that I have assured you, at the end of this session, you will be able to read the CT brain in your emergency. So 5 steps. Just remember the 5 steps while reading the CT brain. And the mnemonic is blood can be very bad. Okay. So first step, look for the blood. As already told, blood will appear bright, hyperdense on the CT scan. So look for any hyperdensities, whether any blood in the CT scan image. Just show me what is this. It is like a happy man face. Okay, and what important structures we are seeing here? We are seeing here the pons, medulla, then thalamus, and the basal ganglia. And what is the pathology? There is a hyperdensity. And one important thing is we are seeing the CT film like this. Our right is the patient's left, and our left is the patient's right. So this is right side of the patient. So we are seeing the hyperdensity on the right side of the CT brain, and it is lens shaped. So what is this? Epidural hematoma. That is not crossing the suture line. So first look for the brain or blood. Okay. Few other hemorrhages on the CT brain. Again, we are looking at the two worm-shaped like images. Okay. So here we are looking the lateral ventricles of the brain. Then we are looking the symmetry of the two cerebral hemisphere. Whether there is a midline shift, I will come on that. And gray and white matter differentiation. But what is the pathology? Whether there is any hypodensity, hyperdensity, or isodensity on this image? Can anybody able to find out? Yes, there is some hyperdensity on the right side of the CT brain. Okay, and that is crescent shaped. Okay, that is fostering the suture lines. Okay, so it is subdural hemorrhage. Okay, so epidural hemorrhage, subdural hemorrhage, then intraparenchymal or intracerebral bleed. Just compare the brightness in both epidural, then subdural, and then intraparenchymal hemorrhage. It is more brighter as compared to the subdural and epidural hemorrhages, and it is mostly present in the basal ganglia. Can you able to what section, as we told for the pneumonia, is a sad man section. Okay, look like a sad man section. What important structures we will see here? Occipital horns of the ventricles. Okay, and this is the hyperdense region on the right side of the city brain, in the right side of the basal ganglia. That is more hyperdense as compared to the epidural and subdural hemorrhage, and this is mostly because of the hypertension. So this is the intracranial or intracerebral bleed. Lastly, intraventricular bleed. Again, to being shaped, we have to look the ventricles in two worm-shaped stages or in the happy man phase stage. So you are looking the ventricles, and here having the hyperdensities in the ventricles, and this is the intraventricular hemorrhage. Similarly, subarachnoid hemorrhage. So first step, when you are taking the CT films, try to identify the neuroanatomy as we told in the mnemonic. Then try to identify any blood in the films. So that is the hyperdensity in the film. Try to identify whether it is subdural, whether it is epidural, whether it is subdural, whether it is intracerebral, or whether it is intraventricular. Second step is cisterns. Blood can be very bad. To see for cisterns. As sir has already told, what are the cisterns? These are CSF filled spaces in the arachnoid matter and PI matter. So what is its importance? It will prevent the brain from the injury. So these are cisterns. Look for the 4 major cisterns in the CT brain. There are many cisterns, as sir already told. On sonography, cisterna magna, they have to visualize. But in the CT, look for the 4 major cisterns. And for that 4 major cistern, look into the 2 images. That is cross-shaped images. That is at the base, and happy man face level. Okay. So 2 cisterns. That is this one is the supracellular cistern. That is above the pons and medulla, supracellular cistern, and around the pons and medulla, it is not PABC. This is a circummesencephalic cistern. So at this level, look for the 2 cisterns. At the happy man face level, look for the 2 cisterns. That is Sylvian cistern, and the face like the quadrigeminal cistern. So first step is identify the 4 important cisterns. At the level of cross, image looks like a cross, and at the level of happy man face. Once you identify it, then try to identify whether there is blood in the cisterns or whether the cisterns are open or closed. Normally the cisterns are open. When it will close? If there is a raised ICT, if there is a herniation, if there is a cerebral edema, this will obliterate. These cisterns will obliterate, and it is the indication of raised ICT. So second step is the look for the cistern. After blood, look for the cistern. Third will be the blood can be, again B. So next B is for the brain parenchyma. Okay. So at what level we will look for the brain parenchyma? In our level, what we made the mnemonic? Bean shape, right? Bean shape. So look the images which look like a bean shape. Okay. And look for the symmetry. Look for the gray and white matter differentiation. Look for any change in the density, whether you are getting any hypodense lesion, whether you are getting in hyperdense lesion, or whether you are getting in the isodense lesion in the brain parenchyma. And look for the important thing is the midline shift, whether there is in a midline shift. So how to calculate the midline shift? Okay, to see the midline shift, look the CT films that are look like a 2 beams. Okay, so that you will get the clear-cut visualization of the ventricles. Draw a line between anterior flux cerebri to the posterior flux cerebri. So this will be the midline. So normally it should not be deviated, or till the 5 millimeter it is normal. But if it is deviated more than 5 millimeter, then we will call it as a midline shift. Okay, so look for the midline shift. We are seeing the CT brain in the emergencies. We are not going to the deeper of the CT brain. Okay, so look for the midline shift. We are seeing the 3 steps. Blood can be very bad. Look for the blood. Look for the cisterns, 4 important cisterns. Look whether the cisterns are open or closed. Look any blood in the cisterns. Then B, look for the brain parenchyma, symmetry, then gray and white matter differentiation, any change in the density or any midline shape. The next will be the very bad, that is V stand for the ventricles. Okay, so first identify the ventricles and then we will see the how to describe the ventricles. So identify lateral ventricles, identify third ventricle, identify fourth ventricle. So to identify the lateral ventricle, look the films which look like a two worms. Okay, and have a visual memory of this size. So we will come to know whether it is increase in size or whether there is a decrease in size. So look the film which looks like a two worms, then this will be the lateral ventricles. Okay, then for the third ventricle, look the films that look like the happy face. And as sir has already told, then this slit-like structure will be the third ventricle. And to see the fourth ventricle, look the films that looks like a cross or at the base. And this structure, you know, the pons, medulla, brainstem, pons and medulla, this will be the fourth ventricle. So V stands for the ventricle. And first step is the identify the ventricle. For lateral ventricles, look like a film that looks like a two worms. Okay, we are making the mnemonics to for our better understanding. For third ventricle, look the films that look like a happy face, and for fourth ventricle, look the film that looks like a cross. Once you identify the ventricles, then look for any pathology. Look its the size, look its the shape, look its the symmetry, look its the density, and look for the mass defects. And from this film, it was clear that it is a case of hydrocephalus. Then last step is the bone. First see for the blood, then see for the cisterns, then see for the blood can be brain parenchyma, then see for the ventricles, and lastly the bone. We are not much interested in the bone. We are already told the highest density on the CT scan is the bone. So look for any fracture for that. So it is the, if you want to summarize how to read the CT brain in the emergency, first identify the neuroanatomy. And for that, mostly it will be in the CT scan, it will be in the axial section. We are not getting the CT films in coronal or sagittal section. Mostly we will getting in the axial section. Go from base to the up and try to identify the neuroanatomy at 6 different levels. That is, it is like a cross. What will you get the cerebellar, then star shape, then happy man face. We will get the thalamus, basal ganglia, ventricles. We can be visualized from above this level. Then we will get the sad man face. Then look like a two worms. Ventricles will be better visualized at this level, and then pin shape. Then pin shape. So this is the normal neuroanatomy. And for reading, read in the 5 basic steps. Okay. So first step is look for any blood. Blood can be very black. Then look for cisterns, 4 major cisterns. Look whether it is open or whether it is closed. That is the indication of rhizolite. Brain parenchyma, symmetry, gray and white matter differentiation. Then ventricles. First identify the ventricles. Okay, where is the lateral ventricle? Where is the third ventricle? Where is the fourth ventricle? And then look for the size, shape, mass effect. And lastly, BAT, this stands for the bone. So this will be the normal neural anatomy and systemic approach to the CT brain in the emergency. Now let's have some exercise. What we have seen till the now, let's try to, just I assured you, at the end you will be able to read the CT brain in your emergency. So what is the diagnosis? First tell me the neuroanatomy and the section, and then we will go to the stepwise approach. So this is the CT brain axial section. Okay, we are looking at the two beams. Two beams. So ventricles are clearly visualized. Then gray and white matter differentiation is there. Now come to the 5 basic steps of the CT brain reading. First I told, look for the blood, any hyperdensities. Are you getting any hyperdensities in this film?
Yes.
It is on the left side. Shape? Crescent shape. Then it is, what is it?
Subdural.
Yes, subdural hematoma. Then next step is the blood cisterns. We are not able to see the cisterns this plane. Then next step the ventricles. Yes, we are able to see the ventricles. Any dilatation or any clean shape the ventricles here. Size? It is normal, but there is some mass difference. Okay, size is side effect. Then look for the brain parenchyma. There is some midline shift. Gray and white matter differentiation is okay. And then bone is not our concern. So this is the subdural hematoma. Another, again, plane is the axial plane. At which level we are seeing? Again, we are seeing as a 2 worms level. Okay. Any pathology? Now come to the pathology. You are seeing any blood, any hyperdensities in this field? No hyperdensities. density. We are not seeing any blood in this. Okay. Second, cisterns. We are not able to see the cisterns at this level. Then brain parenchyma, any hypo, iso, or hyperdensities in the brain parenchyma can be seen in this case. Yes,
Hypo.
there is a hypodensity. Look, this is like a CSL. Okay, take as a brain parenchyma as a reference. Okay, so it is a hypodensity on the right side of the brain in the territory of. This will be the so long, so large.
MCA there is
Right. This is a right MCA will fall. Okay, so it is that easy. So we have to go on the step by step. Then we have to be able to identify the at least emergency. We are not going to the deeper. Whether there is a hydrocephalus, whether there is a stroke, whether there is a bleed, whether there is a mass effect, whether there is a midline shift. Next, again, plane is the axial section. At which layer we are seeing again two. Again, one section. Any bleed in this CTMA? Yes. And which side?
Extra.
Yes. And side?
Right.
Right side. Right. I told it is opposite.
Right.
Our right is patient left. Our left is patient right.
On the right.
So it is the right side. It is shape
From lens.
lens shape. Okay. So it is as Sir was told rightly. It is the epidural line. So next is the blood cisterns. Are we able to see the cisterns in this field? You are not able to see the cisterns in this field. Cistern ventricles. Yes, ventricles are thin, normal in shape, no any mass effect. Okay, can be very bad. Bone it is the bone. We are not able to do the bone. So it is the epidural hematoma. Last one, two more images. So what is the plane? Axial plane CT. Okay, at what levels we are seeing? We are seeing at the again 2 ohms because the ventricles will better visualized at this level. Okay, so 2 ohms. Any hyperdensities in this field. First we have to look for the blood. Any hyperdensities? No, there is no any hyperdensities. Okay, then cisterns again not visualized. Then brain parenchyma. Brain parenchyma is okay. There is no any mass defect, no any midline shift. Ventricles. It is dilated. Ventricles are dilated. So this is a case of hydrocephalus. And lastly, again, at which level we are seeing? In neuroanatomy. It is the axial section CT brain level. Happy. It is like happy membrane. Sadness will be like this. It is the happy. And the neuroanatomical structures. What will be this? Right. What will be this? Basal gang. Right. What will be this? Ventricles. Right. Okay. And what is the pathology first step? Any hyperdensities?
Yes.
Yes, I repeat. At what level it is? At what side and what level?
Right side.
Right side. And what is it? I have already told it is more hyperdense. So it is the and location also saying it is the intraparenchymal or intracerebral hemorrhage on the right side of the brain. Okay, so this is
And there is a scalp hemorrhage.
yes, sir. This is some scalp hemorrhage also. So major pathology along with this scalp hemorrhage also, where sir has rightly pointed. Okay, so thank you for this. As we all know, we have to use the CT scan very judiciously because what detect the cancer that can also cause the cancer. Use it judiciously when it is only indicated. In emergency, when patient is hemodynamically not stable, if you are suspecting hemorrhage, calcification, otherwise it is better to go with the MRI, that is the investigation of choice, where we will have the better visualization of the brain parenchyma. And remember the mnemonic 5 basic steps, blood can be very bad. Thank you.
Very good question. Ask for the MRI. Yes, I know. Because the noise is so much. And to study these children, what to do?
Sir, most of the newborn will be sedated by the feeding also. Breastfeed. If it is not, then we can take the oral medications like pediclorine, hypofloss. Then we can take the phenergan also. Very few cases it will require anesthesia. I am talking about the newborn. Otherwise, with feeding, with oral medications, we can able to sedate them. But in the children, yes, definitely they will require 5 years, 6 years, 3 years. They will require the anesthesia. Most of the times they will not be able to sedate on the oral medicines. But newborn while feeding also they can able to sedate.
Thank you, Dr. Sri Ganesh. Now we will have the inauguration ceremony. I welcome Dr. Sunil Ghate sir, former dean, my teacher, I hope everybody is teacher. Please come up stage. Today's speaker Dr. Hirekevir sir, Nakate sir, Dr. Sri Ganesh, Sahib, please join. Dr. Abhijit, he is an orthopedic surgeon. He is in charge of health unit at University, Solapur University. With them, please. Thank you, dignitaries on the dais. I will ask Dr. Ghate sir to say a few words about that. Today he is our MMC observer also.
Thanks for calling me as an observer. I wish best success for this today's workshop. My sir is here, Dr. Kasliwal. I think the attendance is less. We have to try for maximum attendance. I think you have to take efforts.
Yes.
And you will succeed in that. Thank you very much.
Yes. I request Dr. Sate sir to felicitate Dr. Ghate sir.
My teacher.
I request Dr. Kasliwal sir to felicitate Dr. Hirekevir sir. Nakate sir. Request Dr. Kasliwal sir to felicitate Dr. Nakate sir. Sir.
Nakate has been one of my most favorite students.
Yes, sir. That's why I asked you to felicitate him. It is always pleasure to take felicitation from the teacher. I request Dr. Ghate sir to felicitate Dr. Sri Ganesh Patil. I request Dr. I request Ghate sir to felicitate Dr. Sahil Savaskar.
I
Dr. Abhijit Jagtap, he is my friend. He is working as a in charge at medical unit at the University Solapur. We have conducted obesity survey in 4 schools actually in the obesity day in the February. So 1200 students, they have given questionnaires of 15 questions and they have replied. Prior that I have taken lectures for them communicating the effects of obesity or what is obesity. What is obesity? So after getting the results, we have submitted all the papers to Dr. Abhijit, and he gave it to his statistics department, and he has concluded the study. So I request him to say words about the study, and he also want to do this research in the same field, that is obesity, in the next 6 months, remaining 6 months, with collaboration with the university. He has assured to give some grant for it also. So I congratulate Dr. Abhijit and thank from the IIT Solapur, and I ask Abhijit to speak few words.
थँक्यू अण्णा साहेब. सर्वप्रथम मी सोलापूर पिडियाट्रिक असोसिएशनचा आभार मानतो की मला हा प्लॅटफॉर्म उपलब्ध करून दिला, आणि अभिनंदन करतो यासाठी की आपण ज्या सोसायटीमध्ये काम करतोय त्या सोसायटीसाठी काहीतरी आपण देणं लागतो, आणि या हेतूने आपण डॉक्टर म्हणून एक संशोधनाचा जो विषय निवडला, ओबेसिटी जो प्रिव्हॅलंट आता सध्याचा प्रॉब्लेम आहे तो निवडला, आणि त्यासाठी तुम्ही जे एफर्ट्स घेतले त्याकरता मी आपल्या सगळ्यांचे अभिनंदन करतो. थोडंसं करेक्शन आहे की अण्णा साहेबांनी मला डेटा दिला तो आम्ही प्रिलिमिनरी अनालिसिस केलं, परंतु मी त्याला कालच सांगितलं की आणखी खूप सारे डीप अनालिसिस याच्यामध्ये करणं अपेक्षित आहे, आणि राईट फ्रॉम रिसर्च जो आहे, रिसर्च करताना आता गॅटेसरिता आहे, रिसर्च करताना रिसर्च क्वेश्चन, रिसर्च ऑब्जेक्टिव्ह शुड बी व्हेरी प्रिसाइजली फॉर्म्युलेटेड, आणि देन ओनली वी कॅन कम टू सम मिनिंगफुल कन्क्लुजन्स. तर हा डेटा अनालिसिस करताना काही पॉइंट्स देखील माझ्या लक्षात आले की काही गोष्टी आपल्याला आणखीन करावं लागणार आहेत. त्याच्यामध्ये जे नंबर ऑफ व्हेरिएबल्स आपण घेतलेले आहेत ते आणखीन वाढवण्याची त्याच्यामध्ये गरज वाटते, आणि कम्पॅरिझन ग्रुप्स आता आपण घेतलेले 4 शाळा होत्या, त्याच्यामध्ये आपण त्या मोस्टली सगळ्या इंग्लिश माध्यमांच्या सीबीएसई बोर्डच्या शाळा आहेत, तर काही कम्पॅरिझन ग्रुप्स जे आहेत ते आपल्याला ऍड करावे लागतील. त्याच्यामध्ये जिल्हा परिषद शाळा असतील, कॉर्पोरेशनच्या असतील, मराठी माध्यमाच्या असतील, काही ग्रामीण भागातल्या शाळा त्याच्यामध्ये घ्याव्या लागतील. तर त्याच्यामधून मिनिंगफुल कम्पॅरिझन करून आपण काही निष्कर्ष काढू शकतो. आपण म्हणतोय ओबेसिटी, ओव्हरवेट हे प्रिव्हॅलन्स, परंतु जो डेटा आपण अनालिसिस केला त्याच्यामध्ये अंडर न्यूट्रिशन सुद्धा फार मोठा त्याच्यामध्ये हे दिसतोय. म्हणजे वी प्रिझ्युम की ओबेसिटी ओव्हरवेट दिसेल, पण अंडरवेट स्टुडंट्स आर मोर प्रिव्हॅलंट हे दिसतंय. आणि विशेष म्हणजे ज्या शाळांमध्ये आपण हा सर्वे केला त्या शाळा सगळ्या म्हणजे चांगल्या सोसायटीच्या शाळा आहेत, तरी सुद्धा तिथं अंडर न्यूट्रिशन दिसतंय. ही एक रिसर्चच्या दृष्टीने पुढचा प्रश्न आपल्याला लगेच पडायला पाहिजे की का असं होत आहे. आणि हे करत असतानाच हा जो सर्वे आहे तो मोर ऑर लेस क्वांटिटेटिव्ह सर्वे आहे, म्हणजे ज्याच्यामध्ये आपण डेटा कलेक्शन जो आहे तो इन अ न्यूमरिकल फॉर्मॅट करतो. पण याच्या पुढची स्टेप किंवा याच्या सोबतची स्टेप आहे की क्वालिटेटिव्ह रिसर्च ही सुद्धा काळाची गरज आहे. व्हॉट इज द परसेप्शन ऑफ स्टुडंट्स, पेरेंट्स अबाउट दिस वेट गेन ऑर अंडर न्यूट्रिशन, आणि त्यांच्या फूड हॅबिट्स ज्या आहेत त्या सगळ्या बद्दलचं परसेप्शन जाणून घेऊन त्याच्यात देखील काम करणं गरजेचं आहे. तर ही अशी चर्चा होत असतानाच त्याला म्हणलं की आपण जॉईंटली, म्हणजे आमचे जे नवीन कुलगुरू आहेत डॉक्टर प्रकाश महानवर सर, त्यांच्याशी आमची चर्चा झाली. तर डेफिनेटली जर आपल्याकडनं जर तसं प्रपोजल आलं तर विल डू अ जॉईंट रिसर्च प्रोजेक्ट ऑन दिस, आणि इतकं सारं काम होईल की याच्यातनं एका प्रोजेक्टमधनं किमान 10 पेपर तरी नक्कीच पब्लिश होईल एवढा मला विश्वास होईल. तर मी पुन्हा एकदा हा प्लॅटफॉर्म मला उपलब्ध करून दिला त्याबद्दल डॉक्टर अण्णासाहेब लोखंडे सरांचा आभार मानतो. इथं घाटे सर आहेत आणि आदरणीय कासलीवाल सर आहेत, सगळ्यांचं मी आभार मानतो.
नक्कीच अभिजित, आपण हा प्रोग्राम एक्सटेंड करूयात. मला जे काही सुचलं माझ्या डेली ऍक्टिव्हिटी मधून, माझं क्लिनिकल वर्क सांभाळून, IIPच्या ऍक्टिव्हिटी सांभाळून मला जो काही म्हणजे जो वेळ मिळाला, मला जे सुचलं त्याच्यातून हा मी ओबेसिटी डे निमित्त सर्वे करण्याचा प्रयत्न केला. ज्या काही अवेलेबल क्वेश्चनरीज इंटरनेटवर होत्या त्या मी त्याच्यामध्ये घालून डॉक्टर गांधी सरांची हेल्प घेतली आणि त्या क्वेश्चनरीज प्रिंट करून आम्ही 4 शाळांमधून वाटल्या. ऍक्च्युली 2000 पेजेस आपण छापले होते, पण वेळेअभावी किंवा शाळांची सुट्ट्या लागल्या त्यामुळे मला बाकीचे 800 पेपर्स काही डिस्पर्स करता आले नाहीत. 1200 लोकांचा हा स्टडी आहे. निश्चितच तुम्ही त्याच्यामध्ये PhD केले मेडिकल रिसर्च मध्ये, आय नो दॅट, बट म्हणजे त्या लेवलचा जरी स्टडी नसला तर दिस मे बी द बिगिनिंग, and with definitely with collaboration of university we can go further, and I hope ki it will happen till our this my presidential post finishes at the end of December. Now I request Ghate sir to felicitate Dr. Abhijit sir.
Okay, so good morning to everybody. So today we'll be learning about the basics of MRI, as Sir has covered the basics of CT scan and sonography. We're just going to the basics of MRI. Right, so the overview of the topic will be, firstly we're talking about the introduction, what is the mechanism, the advantages and disadvantages, what are the sequences which are present, what is T1, T2, SWI, flare, diffusion weighted, ADC, what are the various types of sequences, what is the indication of each sequences, what is the importance of each sequence. Along with that, we'll be talking about brain MRI contrast, in what pathologies, what it can show, MRA, MRV, MRS. Coming to the spine, the neuroanatomy, it includes the brain as well as the spinal cord. Okay. Yeah, so coming to the MRI, so MRI is magnetic resonant imaging. It's a short form for that. It's a non-ionizing type of radiation, and it was used previously before in 1960s. First image was being formed, and then it was remodelized, and finally we have a very high soft tissue images, qualities of images now. Based on the quality of Tesla's 1.53, even Ames has now 7 Tesla. So, as mentioned previously, CT scans have the density word, MRI has intensity word, right? So, if it is a bright, it is known as hyper intense. If it is dark, it is known as hyper intense. Coming to the next part is the working of MRI, how it works. It's very complicated, but I've just simplified into a very fine structure. So, 3 main parts. First, what happens is a magnetic field has been introduced, then a radio frequency pulse has been applied. The radio frequency pulse, when applied, each molecule has a threshold of getting excited, and when it is withdrawn, there occurs a relaxation phase. During this relaxation, the time that is taken for relaxation, it depends on either it is a T1 time or a T2 time. So based on it, there is further differentiation of the images. So that is just this mechanism. So first what happens is, normally the atoms are spinning at a very random haywire notion, no perfect sequence, but when we subject them to a magnetic field, they arrange themselves in north and south according to their own atoms and perspectives. Then radio frequency pulse has been applied, and this causes excitation of those atoms, and then followed by there is this withdrawal of this radio frequency pulse, and then there is a follow-up relaxation, during which there occurs a specific image which is formed, and we get a MRI. Coming to going through immediately the advantages. So firstly, it is a non-ionizing radiation. Multiple planes can be studied together, like sagittal, axial, oblique, coronal. Superior soft tissue images as compared to CT scan. Advanced technologies like diffusion weighted for stroke, MR spectroscopy, and perfusion images can also be done. Posterior foci is easily visualized, can detect old as well as new hemorrhages, and can detect infarct within 30 minutes of the infarct that has occurred. Disadvantages being that it is mostly expensive, it's noisy, children can be claustrophobic, And foreign bodies and implants are a strict contraindication. You cannot perform MRI in those cases. So what we'll be learning now is just sequences, right? So what is a T1 sequence? Okay. So T1 sequence, what you can understand by the term, so white is white. White matter, this is the white matter, it looks white. Gray is gray, okay? And CSF is dark. So this is the highlight of T1 sequencing. So whenever you get a MRI, you are firstly identification of what sequence it is. It's much more important than identifying the pathology. So first, if you don't know the basics, you cannot go ahead with identifying the pathology. So T1 sequencing, fat is brighter. That's why white matter is bright. Water is dark. That's why CSF is dark. Gray matter looks black or slightly gray. So what is it used for? It is used for vascular changes, disruption in blood-brain barrier and anatomical detail. So based on it, it is either a coronal image, axial image or a sagittal image. We'll be coming to the neuroanatomy in subsequent slide. This is a T2 weighted sequence, right? So T2 weighted. What does T2? World War II, WW2. So water becomes white on 2, T2, right? So here there is completely opposite of T1. Here the CSF signaling is brighter, white matter looks darker as compared to the gray matter. Okay, so it's used for the same thing, much more better anatomical detail than T1, and also you get vascular changes and disruption of blood-brain barrier can also be seen. The only disadvantage of T2 being that the periventricular lesion cannot be distinguished very properly because the CSF has a very bright signal, right? So for that matter, we have come up with something which is known as FLARE. Okay, so what does FLARE stands for? Fluid attenuation inversion recovery. In simple terms, the fluid signaling is attenuated. See this. Here the fluid sequence is brighter. Here the fluid sequence is darker. Right. So the fluid sequence is taken and its intensity is attenuated and then it comes up. Now why this is important is because you can understand very well the intraventricular pathologies, focal cortical dysplasias, tumors, metastasis, and all these vascular structures. You can understand it very well much on FLARE rather than on T2 weighted imaging. You can, but it is much more important when it comes to FLARE. Correct. So how do you identify FLARE? It is same as T2, but CSF is dark. Here you can see that the white matter is darker, gray matter is gray, lighter than that, and CSF signaling is darker. Same as that of the T2, you can see gray matter, the white matter is black, gray is lighter, but CSF is brighter. Right. So what is it used for? It is used for delineating lesions near ventricles, same as T2, edemas, for gray matter, white matter differentiation. It is much more used. So what is the importance of FLARE? So if we come across this MRI, so we might just go quickly and think, yes, probably it is normal. You know, there is nothing pathology, it looks normal, it's an axial T2 weighted imaging. Okay. But if we see in FLARE, you can clearly see that there is this T2, there is this FLARE hyperintensity which is seen over the right parietal, frontoparietal region, probably a focal cortical dysplasia. Could be easily missed if you don't look at the T2 weighted sequencing along with FLARE. Same example, see this. It could be easily missed if you don't look at FLARE. Due to the CSF signaling, this can be mirrored or it can't be overcome. So hence FLARE has been introduced for further simplification. The next sequence is DWI sequencing. How to identify a DWI sequence? So what is DWI? Basically diffusion weighted imaging. So how do you identify it? The bone window is absent. See this bone window which is typically seen, right? Okay, this is absent. So this works on the principle of this of diffusion of water molecules across the cells. So bones are supposed to be non-living tissues, so they don't have the water diffusion molecules. ATPase pump doesn't act there, so that's why there is no signaling which is seen. So it's just FLARE with poor quality FLARE without bone window, right? So this is FLARE, this is bone window. You can see the gray-white matter differentiation here. DWI, yes, you can see, but it is not that clear with low resolution FLARE imaging with no bone window is typically a DWI, that is diffusion weighted imaging. Okay, so what is the importance? It basically measures the diffusion of the water molecule across tissue. So consider a part of stroke. Okay, a child has a stroke, then there has a failure of ATPase pump, there occurs cellular swelling, there occurs free limitation of water, and it looks hyperdense on DWI. So the term hyperdense or restricted diffusion is only limited for DWI images. Okay. Giving you an example how it looks. So this is how it looks, right? So this is how hyper intense it looks on DWI sequencing. So correspondingly, there is something known as ADC, apparent diffusion coefficient. Just imagine as a T2, but a low resolution T2. Why T2? CSF is darker, white matter is darker. CSF is brighter, white matter is darker, and very low resolution. You cannot see the cortical differentiation as such. Okay, so here it is similarly what you can see in here. There is a darkening on ADC. So when it comes to this, together it has to be read. ADC and DWI sequencing together they have to be read. Then what we say when we come to a conclusion is something known as this. So there is a restricted diffusion which is seen on DWI, or hyperintense seen on DWI sequence, and corresponding darkening on ADC. Corresponding, which is shown same area is affected here dark, which is on ADC images, right? Okay. There is something known as SWI sequence. So SWI stands for susceptibility weighted imaging. Okay, how will you identify it? Firstly, it is a very low resolution. You can clearly see the blood vessels in that. Ventricles are not very clearly seen, but they are seen. Not that high resolution as these, as the flares and T2s, right? Okay. So, yeah, so it is best for blood products. It is best for bleeds. It's best for calcification. Okay. So, what is the clinical application of these? You can see intracranial hemorrhage, especially small hemorrhages, delineation of small vessels, evaluation of traumatic brain injuries. You can see for neoplasms, cerebral infarctions, and vascular malformations, and hemorrhagic brain lesions. Okay, this is how it looks. So this is a man who has had more lacunar infarcts, probably due to hypertensive bleed. You can see the term blooming is used. So whenever you're describing SWI sequence, you have to use the term blooming. In report, they will be say multiple areas of blooming were seen on SWI sequencing, right? So it looks darker. So this is SWI blooming, which looks. How will you identify it? Same. The blood vessels looks very prominent. Ventricles are not that prominent, but yes, there will be this darkening, which either could be a bleed or calcification based on the pathology. Coming to contrast. Contrast is something which I get a very frequent call. We have to do an MRI of a patient. Should we do a normal MRI or a contrast MRI? Correct. So contrast MRI is always indicated when you're suspecting some infectious pathology or autoimmune or para-infectious pathologies. Okay. So firstly, in CNS infections, demyelinating diseases. In GBS, never forget, in GBS, brain plus spine contrast. Because in GBS, what happens is the lower end, the chorda equina, also has contrast enhancement. So it could be missed. So that's why I always tell my residents to do contrast imaging when you're suspecting a case of infectious or para-infectious diseases, right? Okay. Then in tumors and in optic neuritis, a female coming with unilateral or bilateral vision loss, then you have to do a dedicated MRI with optic nerve cuts, with contrast and spine. Why? Because you need to rule out if it is an NMO, MOG, you have to find out if the spine is also involved, if it is associated with transverse myelitis or something like that. So always, contrast is very important. How will you identify a contrast imaging? Is basically for what commonly in practice what we do is we do what T1 contrast. Okay, so T1 contrast is something known as T1 plus contrast, right? So in T1, what will happen? The white matter is white, the gray is gray, CSF is dark, and there is this alienated blood vessels, which are showing the contrast. So based on it, there is this, based on the pathology, where the contrast uptake is much more, where it is there, it is further divided. So a normal will look something like this. Dural enhancement or pachymeningeal enhancement will look something like this. There is complete enhancement, just the dura matrix involved. Leptomeningeal enhancement. This is something which will come up across in very infectious diseases or even tumors also, meningeal tumors also. There is diffuse leptomeningeal enhancement. There is focal enhancement, then there is chiral enhancement, and there is also periventricular enhancement. So these are the type of enhancement that we get when we come to the MRI. Correct. So what is the importance of this contrast? This is a child who you get an MRI of this child. Okay, you are seeing is probably looks like some tumor or some space occupying lesion in it. You're not very sure what is it. Okay, so what sequence is this? Anybody? Now you have talked all this. What sequence is this? T1. T1, correct. So it's T1 sequences, right? Okay, so T1 sequence, right? So T1 sequence, you can see that there is this hypointense lesion which is seen in the right temporal region. All right. Similarly, on FLAIR, that you can see that the same lesion is showing it's circular, and also it has a perilesional edema, signified by the fact that it has a hyperintense shadow along the thing. But if we missed contrast, we have not done the contrast, then we will just come to a conclusion, probably it must be something tumor or something. But when we do a contrast, it comes to a lighting that yes, it is a ring enhancing lesion, right? So see this ring enhancement, it is clearly seen. Not just ring enhancing, there is also multiple septi are also seen. See this one pocket here and one pocket here, which are clearly missed here. Right, so that is the importance of contrast. If you forget to do contrast in a child when you're suspecting infection, should always go for contrast. It will make your job and the clinician and the radiologist's job all easy. Everything will be there. Patient job will be easier. So that फिर से MRI करना and ये सब चीजें नहीं, it is not possible. Right. Coming to the next part, which is MRA, MR angiography. So firstly, there are two parts in it. It is not just one part. Yeah, so the next part is MR angiography. So first you can see that there is, this is nothing but to just mug up. You have to have a pictorial memory of it. Without that, there is absolutely no way that you can have a very clear-cut knowledge of this. You have to just mug up and just remember it. What do you remember whenever you see an MRA? Okay, so firstly, so these are the internal carotids. They are coming together. Okay, fine. Then they form a loop. Okay. And then this is the MCA and its terminal branches. This is the MCA and its terminal branches. This is the ACA and its terminal branches. This is then gives out these posterior communicating branches. Then there is the basilar artery. Then there is the vertebral artery. Okay, this is how it signifies on the diagram. Diagrams makes us more clariform and all the things. So circle of Willis. So this is the circle of Willis, right? So this is important. You have to remember this. So whenever you are identifying a anterior stroke or a posterior stroke, it is much more important. You can understand the pathology and all these things. Next part, for the posterior stroke, if you are suspecting posterior stroke, you should always order for MRI neck resonance. Always. Why? Because usually in vertebral artery strokes, in pontine hemorrhages, pontine strokes, you will get vertebral artery attenuation or abnormalities, and that can be easily missed if you don't order for MRI contrast of MRA with neck vessels. Correct. So these are self-explanatory. This is the basal artery, vertebral artery. Then vertebral artery has 4 parts: part 1, part 2, part 3, and part 4, where it eventually joins the right and left subclavian artery respectively. So coming to the MRV, okay, this has to be again mucked up. Okay, MRV is very simple as compared to MRA. Few important structures that you need to understand. First is the sagittal vein. Okay, very nice, very good. Then there are a few cortical superficial veins. Then there is this transverse vein. Then the sigmoid sinuses, and then eventually the sigmoid right and left sigmoid sinus. They eventually land up into right and left jugular vein. This is the coronal imaging from behind, and this is the sagittal imaging. In sagittal image, there is one more thing which is known as the internal cerebral vein and the vein of Galen. Okay, so these are the important things that you need to worry about. Now, which in cases which you order for an MRV is when you're suspecting the child to be having cavernous sinus thrombophlebitis or thrombophlebitis of the veins, which is very common. The child coming to you with diarrhea and suddenly has a focal seizures, and then yes, you can think of it. And anemia, diarrhea, dehydration. These are all the risk factors for sinus venous thrombosis. Okay. So something which is very interesting and very new concept, not new per se, but it is a very interesting concept is MRS, MR spectroscopy. So what happens in spectroscopy is that a chunk of the brain parenchyma is taken, extra radio frequency waves has been ablated to it, sent to it, and based on that, the excitation of the molecules has been taken and that is being calculated. Okay, it's the very simplest form, even that is the most complicated and the most simplest form ever. So based on it, few normal structures have a very distinguished resonance. So your resonance has been calculated, and based on the resonance, you can identify the pathology. I've just given you this normal MRS. Okay, so first, what we look at is first lipids. So they resonate as 1.3 ppm. So this is parts per million. So 1.3. So here somewhere there will be lipid peak. Okay, so suppose the child has a tuberculosis, a tuberculoma, and you do an MRS, correct? So here, if you specifically do it, there will be high lipid peak, which will be seen in tuberculosis. Okay, same goes for lactate. Lactate 1.33. Lactate goes for 1.33. So in mitochondrial diseases, there will be a high lactate peak on MRS. Okay, and there is N-acetyl aspartate. See this NAA. Okay, so this is a N-acetyl aspartate peak, which is high NAA peak, which is seen in Canavan's disease. Correct. And the next is the creatinine, which resonates at 3 ppm. Right. This is the CR. Right. Okay. So what is that importance? This peak will be reduced. Okay. There is something known as cerebral creatinine deficiency. A child coming to you, a male child with unexplained global developmental delay, when you do his MRI with MRS and you see the creatinine peak is small, then you think that yes, cerebral creatinine deficiency is there. You just start the child on creatinine powder that the gym people take for bulking up, and immediately the child is doing very well, right? So cerebral creatinine deficiency can be diagnosed due to this. Okay, now coming to the neuro anatomy part of the lecture. So we'll be going from top to the bottom, then we'll be going to sagittal, then we'll be going to coronal images, then we'll be going to spine, then axial spine and sagittal spine. Okay, so firstly I'll just overview. This is the topmost part. You are not seeing any sequencing. So which sequence is this? It's an axial T2, correct. So it's an axial T2 sequencing. Okay, so this is frontal lobe, frontal part, right? This is the temporal region, rather the parietal region, and then this is the occipital part. And this is the central semioval, this is the white matter. Okay? Okay, so this is important in neonatal stage where I have not taken myelination as such, but the first thing to myelinate at birth is usually this part, along with the posterior limb of the internal capsule and everything. Okay. Next, just below that, the level below it, it is this. This is for your, you can understand, I've just marked here so that you can compare it with both of the sides so that you can understand. This is the frontal lobe, this comes the parietal lobe, this comes the temporal region, and here is the occipital region. Also, along with that, these two markings that I have done, these are both of the lateral ventricles, but this is the frontal horn of the lateral ventricle and this is the occipital horn of the lateral ventricle. Okay. Further, what do you see now? This red part that you can see, it is the caudate nucleus, right? This is the globus pallidus and putamen together. So globus pallidus internus, externus, putamen, right? Okay, this is the insular cortex, right? This is thalamus. Okay, thalamus. So if you can see that there is this V shaped, right? V, right? So V. This is nothing but the internal capsule. So it has two parts. Okay, the anterior limb as well as the posterior limb of the internal capsule. Okay. This green part which is there between the insular cortex and the globus pallidi and putamen, this hypo-intense on T2 image, which is this is the external capsule. Right. So this is something known as external capsule. Okay. Then what is this? This is the splenium, genu of the corpus callosum, which is connecting both of the fibers. Why genu? Because it is white matter, it is dark on T2, right? So it is genu of the corpus callosum. Okay. Coming further down, that you can see, further down, this is the frontal lobe, this is the temporal lobe, this is the occipital lobe. Okay. Along with that, you can see this structure here. Yes, this is the cerebellum. Right. Then you can see this butterfly shape here. This and this butterfly shape. Okay. Yeah. And this is the anterior part of it, which has the pyramidal tracts. This is the bilateral nucleus, red nucleus, and stuff. This is the midbrain. Correct. So this is the midbrain. Then there is this red intermittent dot that you can see. This is coming and going. Yeah. This is the third ventricle. Okay. Right. Coming further down, if you see, the structures become much more complicated, and rather they have become much more complicated than the previous before. Okay. So this is the temporal lobe, and this is what? The cerebellum. Correct. And this part is the vermis. I have marked it. This is the vermis, right? This is the vermis. Okay. And the part connecting the cerebral and this is the cerebellar peduncle, which is the middle cerebral peduncle, which comes mostly from the pons. Yeah. And this is the area in which there are cerebellar nucleus, involves the dentate nucleus, fastigious nucleus, right? Cerebellar white matter. Correct. And this is the pons. Along with that, you can see that this is optic nerve, and lastly the fourth ventricle. We can see this here. Correct. Coming to the sagittal section, now we have covered the axial section, important structures. Now we are coming to the sagittal section. So in sagittal sections, this part is taken up by the frontal lobe, right? Okay, so frontal lobe. Then there is this parietal lobe. Then there is this occipital lobe. Okay, if you see the lobe-wise distribution. Then there is something occurs in the cerebellum. Okay. Then there is this red shadow which is present and which has been taken very in high details by Hirakaru sir. This is something corpus callosum, right? So it is there. So it's briefly can be divided into three parts: the genu, the body, and the splenium of the corpus callosum. Then there is this thalamus and thalamus. This is the third ventricle. This is the midbrain. A pregnant belly that you can see here, a bit of pregnant belly which is known as pons. Then there is a midbrain, and then there is the spinal cord. Okay. And there is this fourth ventricle at the in between the pons and the cerebellum. Okay, coming to the coronal sections now. We are coming to the coronal sections in detail. So why coronal sections are necessary? Firstly, we need to visualize the hippocampus. Because it's a part of the neocortex, and usually in epilepsies, the hippocampus gets fried up in your mesial temporal lobe sclerosis or something like that. Hippocampus is the source of epilepsy, so you need to be very vigilant. And when you're ordering for a case of a child who has come to you with epilepsy, always mention MRI brain with epilepsy protocol so that they take a dedicated oblique cuts which involves the hippocampi also. Right. Okay. So this is the frontal lobe, this is the temporal lobe, this part is the insular cortex, right? So this is the frontal horn of the lateral ventricle, this is the temporal horn of the lateral ventricles, the blue part, then this is the caudate nucleus, then this is the putamen, then this is the lentiform nucleus, rather the lentiform globus pallidus internus and externus, and then at the last it comes to the internal mammary bodies basically. Okay. Hypothalamus is something which is very important when it comes to radiological point of view for a neurologist, because we have to compare it to rule out dysplasias, to rule out swellings, because in most ictal phases there can be seizures which can lead to that. And at the end, this is the connecting white matter in between. This is the again of the corpus callosum. Okay. Yeah. Just we are going now to backs, just to behind one important region I have to mention. This is the frontal lobe, this is the insular cortex, this is the temporal lobe and hippocampus here. Okay, this is the frontal horn of the lateral ventricles, this is the third ventricle, this is the thalamus. This part comes as the midbrain. This is an oblique section. This is what they do when they order for a epilepsy protocol. When you specifically order for an epilepsy protocol, how they see. This is the midbrain, then this is the pons, and here are the this is the globus pallidus internus, and these are the two red nuclei which are typically seen. Okay. Coming to the anatomy of the spinal cord. Correct. So when this is a T2 weighted sagittal image, okay. So T2 weighted sagittal image. So first this we will look. This is explanatory. It's given there. Okay. So the first red dot that you can see, this is the midbrain. Then comes the pons. Then comes the medulla. Right. Okay. Apart from that, there is the blue sequencing which I have used. That is for the fourth ventricle. Then there is cerebellum. Okay. And then there is spinal cord. So when you see spinal cord, usually the question which is asked is C1 vertebrate body. Yes. So C1 vertebrate body is here. So this area is for this. Right. Along with that, the green part I've marked, which is the body, and the red part that is there, which is the intervertebral disc. So it's, from there, C1, C2, like subsequently you can have a marking and recognition of what sequence it is or what level it is based on it. Correct. Similarly, this is a sagittal T2 weighted imaging which is showing from C2 till the end. Just this one, this is an enlarged image which is showing T12 to S2 vertebrae. Much more for anatomical localization. You can see that the spinal cord ends at the T1 vertebrae, which forms the conus medullaris, and then there occurs chorda equina and the things. Coming to the sagittal, the axial sections. Now we saw the sagittal sections, right? Axial sections. How will you identify a vertebrae? So firstly, if it is a cervical, thoracic, or a lumbar. So firstly, you can see I've given a normal diagram of a vertebrae. This is mostly a cervical vertebrae. How will you identify? Square-shaped vertebral body. It also has a transverse processes and a spinous process with the facet articulation, superior articulation processes in that. What makes it, this is a spinous process, what it makes difference, how will you differentiate cervical, thoracic and lumbar is basically presence of these two extra openings which are present, which are the vertebral arteries opening, right? So that's how you will understand if it is a cervical vertebrae or a thoracic vertebrae or something like that. Correct. Then this is the, you can see this orange marking I've done here. This is the ligamentum cruzum, ligamentum clavum, and this is the posterior longitudinal ligament. Correct. So these help the spinal cord and the vertebral structure to be in a same place. Okay. And this is the remaining, the spinal cord. You can see that there is this H structure, the gray and the white matter there, right? Okay. So how will you identify a thoracic vertebrae whenever you are doing it? So thoracic vertebrae is something which has a round and bean or ovulated body. Along with that, the opening is proper ovule. Okay. There is this transverse processes it has a spinous process. Then there is this facet processes which are there and the spinal cord. Then coming to the further anatomy of the lumbar vertebrae, as you can see that there is no openings for the vertebral artery. The transverse processes are just shifted slight to the posterior side, right? So this is the posterior, this is the anterior. So here you can see that they are just shifted behind. Coming to the other part, this is the lumbar vertebrae. This is a bean-shaped or a kidney-shaped body with triangular. It's not looking much triangular, but you can see that there is this chorda equina of the cord. Then there is this huge body, and usually near the spinous process there is this facet articulation which are typically seen. So this is how you will understand how a typical lumbar vertebrae works. Sure. So thank you very much.
Thank you, Sahil. Very simplified and diagrammatic presentation. Next speaker, Dr. Nakate, to speak more typhoid vaccines.
We are coming across very few cases. Incidence has been drastically come down in last 10 years. As we were the residents and when we were the PG students, we used to get so many cases of tuberculosis as well as enteric fever or typhoid fever. And basically the diagnosis was clinical as well as laboratory diagnosis. And to differentiate, most important nowadays, the most important thing that needs to be confirmation of diagnosis for typhoid fever rather than the routine investigations like Pediatric tests and all that. So many patients come to us with all the reports and all that. But nowadays, the diagnosis of typhoid fever has become more and more difficult because most of the patients are receiving antibiotics on day 1 or day 3. Again, it is a problem of antibiotic rationalism, and we, the IP and we all pediatricians are fighting on for that because since last 30 years, we don't have any new molecule of antibiotics, and nowadays we are getting much more antibiotic resistance for most of the cases, those who are getting admitted in the ICU. So, it is very difficult, but the gold standard or the rational test for diagnosis of typhoid fever is the blood culture, and which is very, very difficult for the yield of the basic. There are a few pitfalls for the blood cultures, and nowadays still last 4 to 5 years because of this backtake and all that, the incidence of blood culture has been increasing. Getting the test by the blood culture has been increasing, but still with the periphery or the general practitioners, those who are doing, they are preferably not preferring the blood cultures. So again, the problems with the blood culture is the quantum or the quantity required, but nowadays with backtakes and all that, that is not again an issue. So around 2 to 5 ml blood sample is again sufficient, as previously we used to have at least 5 to 10 ml. So getting that particular blood sample in neonates as well as in the young children was very difficult. So we should promote for going for the blood cultures and the various new techniques. And again, the blood cultures, the duration of time required for the reporting was at least for 3 to 7 days. But with these advanced techniques of blood culture and all that, we are getting the reports at least within 24 hours, and sensitivity reports even better than 72 hours. So we should promote, or we should go for these gold standard investigations and come to the final conclusion or the definitive diagnosis. So coming to this typhoid, Salmonella typhoid has 2 antigens, that is O antigen and VI antigen. So and the third one is the H antigen. And depending upon this sensitivity, we used to have Vidal test, that is type H, type O, and type VI. So nowadays, as I mentioned, the incidence has come down. Still, the incidence that is recently mentioned in 2021 survey, it is in the range of 1.5 to 3 to 5.5 in the range of age group of less than 5 years. And with the age of 5 to 10 years, the incidence is in 3 to 3.5 per 1,000 cases. So this is the chart showing the disease burden in children. Again, the typhoid has the higher incidence in children compared to the other age groups. So, as I mentioned, basically diagnosis again, clinical diagnosis as well as pathological laboratory diagnosis that I mentioned in details. But the clinical diagnosis again, most important is the fever, and this classical fever is more than 38 degrees centigrade, and the characteristic of this fever is the same bladder pattern of the fever. And again, as I mentioned, this Vidal test has its own limitations, and definitely on that basis we cannot have the incidence as well as the clinical diagnosis or the confirmatory diagnosis of the with the Vidal test, though it can be used as a screening test. So I then mentioned the antibiotic microbial therapy, the difference between the resistance of the antibiotics. Again, initially we used to have chlorantraniliprol as a drug of choice. In between, then came the protenolols. Then they have their own limitations in neonates as well as young children. And then again, the new molecules are the cephalosporin, that is third generation cephalosporin, that is ceftriaxone, and even cifotaxime. They have got sensitivity. But in last 10 years, Again, because of the use of these newer molecules, that is ceftriaxone, patients are getting again resistance with the ceftriaxone, and few of the patients are again coming back to the reassurance with the they are responding to the chloramphenicol. So this is the variation. But again, as I mentioned, antibiotics has to be chosen by very rationalism. So again, because we are going to land up with this antibiotic resistance problem in each and every case. So again, I mentioned there is antimicrobial resistance, especially for this again for the Salmonella typhi. This is mainly because of the irrational prescriptions, the non-compliance of the patients, and disposal of the drugs. Non-compliance is again a big issue in our day-to-day practice also. Even if we prescribe the medications or antibiotics for 3 to 5 days, patient miss at least 1 or 2 doses. Similarly, for this, as the typhoid fever requires minimum duration of therapy 7 to 14 days, then again there is compliance is the major issue. That's why the resistance cases of typhoid fever are coming across. So this is the incidence with with antibiotics resistance and this vaccines development. In last 10 to 15 years, this antibiotic coverage in last 10 to 15 years, we have got the maximum coverage for typhoid vaccine, and then again we are able to decrease the incidence of this typhoid illness. So we have seen typhoid and antimicrobial resistance. So to reduce this burden of typhoid fever or the anti-fever, the only solution that can be helpful is the typhoid vaccine, effective vaccine. So we'll coming to the conjugate vaccine. So what differentiates typhoid conjugate vaccine from the traditional vaccines? Mainly it is the polysaccharide vaccine and a polysaccharide conjugate vaccine. So the difference between this polysaccharide vaccine, it adds up the B cells and the antibodies are prepared, but they don't have the immunity. But in case of polysaccharide conjugate vaccine, where both B cell as well as T cell, and then there is separation, there are antibodies plus immunity. So affinity is maturation, induction of the memory cells, and long life antibody production, improved immune response in the infants. So this is the characteristic feature, and that's why this is important. So, see the difference between conjugate vaccines. It is mainly the scale similar. The vaccine is the B cells and the TCV is B and T cells. Antibody titer is low in case of VX. The titers have been very high. The quality of antibody is low in case of polysaccharide, and the capsularity is high. Self-limiting immunity is absent, especially in polysaccharide, and it is present in conjugate vaccine. Duration of response is short-lived and duration of long-lived. That immunological immunity is more strong. So these are the basic differences between the polysaccharide and the TC vaccine. So do you see that whether all these conjugate vaccines are the same? But that mainly depends upon the polysaccharide and the source, the length, and the duration. So these are the technical details, and so we'll not go into the details of this all polysaccharide vaccines, how they are prepared and all that. And then, so about the features of this type of vaccine is the only type of conjugate vaccine with long-term safety and immunogenicity. Then is the only conjugate vaccine with proven efficacy, and it is proven booster dose effect, and it has proven non-interference with the MMR vaccine method, and it has proven safety and effectiveness in the elderly people. So these are the features of typhoid vaccine. So again, these are the various different trials and its regarding its immunogenicity and efficacy. Again, I am not going to go into details. So as far as safety is concerned, there are various different studies from India as well as other countries, and this is especially from India and Maharashtra. There is safety above the age of 9 months to 14 years, and definitely about 1 lakh children were vaccinated and 5,600 telephonic interviews were conducted, and most common local is plain anti-site adverse effects. And as far as systemic adverse effects, there is no any systemic adverse effects for the vaccine. And again, they have got even study across the world itself, and they have recently published a paper in the Lancet also. So again, I'm going to differentiate between these regular vaccines, polysaccharide vaccines, or the other comparison between the why this is superior or why the has got these positive points. That is, target population is less than 6 months also, that is 6 months to 6 years or 65 years. Then human challenge studies have been done. Then efficacy is around 70 to 80%. And this other with this, the data is not available. Then administration with MMR vaccine and yellow fever, that is again recommended for this vaccine. And it is mainly the control studies of the temperature is blind. Then post-marketing survey. So these are the positive points for this typhoid vaccine. Thank you.
Proceeding further, we will have a tea break of 5 minutes only. So that already we have late by half hour.
Captured by opportunity. You will want certain pathological conditions, and these are the few pathological conditions that we will be seeing. Okay. Now the Arnold-Chiari malformation. Now what is this Arnold-Chiari malformation? What happens in Arnold-Chiari malformation? Basically there is a meningomyelocele. So there is decompression of the fourth ventricle. There is a small undeveloped posterior fossa because the posterior fossa structures have now come down. Because of this, the tentorial attachment also becomes low. The cerebellar tonsils vermis are displaced into the foramina magnum. Pons medulla are also displaced interiorly. So this is that line. This is the clevis of the base of the skull, and this is the foramina. So this line, below this line, this is the demarcation. So the posterior fossa structures, they go below this line. Okay, so now who has the pointer? Now enlarged lateral ventricle with occipital horn larger than the frontal horn. Now what we Pooja, can you point to the occipital horn? Very good. So that is the occipital horn. Which is the frontal horn? Frontal horn is there, up pretty bit up. Yes. So the occipital horn has become very thin and the occipital horn has become large, and this condition is called colpocephaly. There is elongation and caudal displacement of the fourth ventricle. So where should be the fourth ventricle? Little bit below. Yes. So it has gone down. The fourth ventricle is elongated, is very thin and is not visualized at all. Actually, literally not visualized. But one more thing which is happened. Where is the cisterna magna? Where should be the cisterna magna? Yes. And it is not visualized at all because now cerebellum has come down and obliterated the space. Anterior and inferior frontal horns, battling appearance, which you can see very easily. This is the battling appearance. The third ventricle is enlarged. Show me the third ventricle. Yes, that is the enlarged third ventricle, which I told you was just 1 mm or 2 mm, but this is quite bigger than that. And the massa intermedia fills the third ventricle. So that particular is not seen here, so you just forget that. Then agenesis of corpus callosum. So I have told you that corpus callosum are the white fibers that join the respective hemispheric structure. So they are the interhemispheric fibers. It consists of the rostrum, genu, the body, isthmus, and the splenium. Embryologically, the genu and body develop first, and then it proceeds anteriorly to the rostrum and posteriorly to the splenium. So when there is a partial agenesis or a total agenesis depends upon the timing of the intrauterine insult. If the intrauterine insult is very early, then the body will also not develop. If the intrauterine insult is late, by that time the body and genu have already developed, the rostrum, the isthmus and splenium will not develop. So it is associated with anomalies in 80% of those cases, and isolated absent agenesis of corpus callosum has a good prognosis. The absent corpus callosum. Now, where should be the corpus callosum? We should have seen. Can you point? A little bit up in the midline, correct. So you have pointed to the midline, that is correct. So that is a place where the corpus callosum should have been there, but it is not there at all. In the upper end of the brain section also you will see that there is no corpus callosum. The C-shaped corpus callosum is not there. there is absolute singular gyrus and singular sulcus. Now what happens is the white fibers of one hemisphere will go to the other hemisphere. Here there is absence of corpus callosum, but the white fibers are present, but they have no place to go because they cannot go to the midline, so they go somewhere else. And where do they go? Instead of going horizontal, they become vertical. So that is the reason that you see this type of appearance. So excessive vertical gyri sulci are seen. So there is a radial arrangement of the sulci, and that is called the sunburst appearance. Action corpus callosum here. Now you can see that there is no third ventricle, there is no corpus callosum in between. This is the dilated occipital horn, and what you see here is that instead of the both lateral ventricles going into the third ventricle, there is as if they are both in communication. So, and the third ventricle, instead of being down, it gets elevated. So the both lateral ventricles and the third ventricle, instead of being separate structures, they are seen as a single structure. Okay, do you appreciate this? This is not normally you see. You see both the frontal horns then going into the third ventricle. But you are seeing that the both lateral ventricles and third ventricle are one single structure. So that was a loss of corpus callosum. Now Dandy-Walker malformation, enlarged fourth ventricle. Can you show me the enlarged fourth ventricle and cisterna magna? Yes, that is the enlarged fourth ventricle. Can you show the cisterna magna? Where you should see? Yes. So that is the cisterna magna, and in the first image you see that it is quite large. More than 10 mm is significant. So large posterior fossa. Because of this cyst in the fourth ventricle, the posterior fossa becomes very large. Hypoplastic vermis. That was probably sir was trying to tell. Hypoplastic vermis will be present in Dandy-Walker syndrome. Brainstem will be small because there is no space there for the brainstem to develop, and there will be obstructive hydrocephalus. So these are the features of Dandy-Walker malformation. Enlarged fourth ventricle connects directly to the Dandy-Walker cyst. This is the Dandy-Walker cyst, and it connects to the fourth ventricle. The cerebellum of the vermis is hypoplastic here. So what I have pointed, what is this? What I am trying to point? This is a large cisterna magna, which is normally not so much large. In presence of this cisterna magna, you should suspect that there is some anomaly. So what are these anomalies which are associated with the mega cisterna magna? One is Dandy-Walker. Second, it can be normal variant also. But when there is only mega cisterna magna, there is no mass effect. In the previous Dandy-Walker, we have seen that there is a mass effect because of which the cerebellum vermis doesn't develop, the brainstem doesn't develop. But such case is not here. There is hydrocephalus in Dandy-Walker. Only if there is mega cisterna magna alone, there is no hydrocephalus. The vermis is normal. Show me the vermis. Cerebellar, yes, that is the vermis. So that is normal. So it is not hypoplastic as in fourth ventricle. Show me the fourth ventricle. Yes, that is the fourth ventricle. And cerebellar hemisphere we are not seeing here because this is a sagittal section. Another cause posterior fossa cyst is posterior fossa subarachnoid cyst. But here the cyst does not connect to the fourth ventricle. The vermis is normal, then fourth ventricle, but fourth ventricle and cerebellum are displaced down. So that was about the Arnold Chiari Dandy-Walker, two common malformations. Now coming to the hydrocephalus. It is easy to diagnose, and if you want to compare the progression of hydrocephalus, you compare with the previous films. Now here, can you show me the somebody else now? Okay, now the first one is the sagittal view. So you show me the third ventricle here. In the sagittal view, the first, this. Yes, that is the third ventricle. That is the scale set point to the third ventricle. Yes, that is the third ventricle in the midline. It is quite dilated. Then in the second coronal view, here. Now what can you show me the third ventricle here? Yes, this is the midline third ventricle. It is very much dilated. Frontal horn. Yes, those are the two frontal horns. Normally they should be comma shaped. We have seen the previous thing. There are very thin comma shaped frontal horns. Here they are completely rounded. And the temporal horns? Yes. Now temporal horns I had told you that they are not normally seen at all. And if they are seen even slightly, then there is hydrocephalus definitely. Then coming to the parasitary. So here what are you finding? Show me the triangle in this. Show me the triangle. Yes, that is a triangle. Frontal horn. Yes, lateral ventricle, frontal occipital horn. This is the occipital horn. And the temporal horn. This is the temporal horn. So the occipital horn, temporal horn, frontal horn all together meet to the point that is called the triangle, and that is itself is dilated. And the fourth one here. Show me the occipital horn here. These are all occipital horns, and show the choroid plexus. Yes, that is the choroid plexus. So I had told you that in the coronal section at the level of the choroid plexus, in the posterior part, the choroid plexus totally fills the occipital horn, because the choroid plexus is maximum in that part, that is called the glomus of the choroid plexus. So glomus completely occupies the occipital horn. And you cannot see any fluid around the glomus. Here you are seeing fluid all around the glomus, and that is why this is a definite case of hydrocephalus. So is it difficult to diagnose? It is not at all difficult to diagnose. Now how to monitor this? So what is done here is that the lateral ends of the frontal horns at the level of foramen magnum. At the level of foramen magnum, the lateral ends of the frontal horns are compared with the biparietal diameter. That is how you compare. And this is called the ventricular index or the Evans index. So you can do it progressively. Today you do, 3 days later you do, and then you try to see when you want to get this operated. Thalamocortical distance. So show me the choroid plexus here first. Yes. No, that is not the choroid plexus. Yes, that is the choroid plexus. The thalamus. Yes, that is the thalamus. So we see the distance between the thalamus and the posterior end of the occipital horn, this distance. And you monitor this distance, that is called the thalamocortical distance. So as the hydrocephalus progresses, this distance will go on increasing. Then coming to the hypoxic ischemic events. For that one should know what is the normal watershed area. So on the lateral surface, so here is the region of the anterocerebral artery, this is the middle cerebral artery, and this is the posterior cerebral artery. And these are the watershed area, means if there is a ischemia, then the infarctions and ischemia will be seen here first in this region. This is the watershed area in a full term child. This is the watershed area in a full term child, which is different from the watershed area in a preterm child. And watershed area in the preterm child is in the periventricular region. This is the periventricular region, and this is the watershed area in the full term child. So, in a preterm child, if you want to see the signs of ischemia, you will be seeing near the ventricles. And in a full term child, it will be away from the ventricle. Now, germinal matrix, I told you, was a fine network of blood vessels and the source of the neural tissue and neuronal cells. It is very much vascular. It will regress as the gestation advances, except in the region of the chordothalamic group. The germinal matrix is highly susceptible to pressure and metabolic changes, leading to rupture of the vessels, because autoregulation here is absent in the preterm. Now, what do you mean by this autoregulation? Whenever the child is in distress, child is anxious, what happens when we become anxious? Our heart rate increases, our blood pressure increases. Similar things when we are examining a newborn child, a preterm child, you try to handle it, the baby gets scared. You wake up the baby from the middle of its sleep, and baby gets scared. What will happen? Blood pressure increases. When blood pressure increases, the blood flow to the cerebrum will increase. But the vessels are able to vasoconstrict, so that not to allow the blood flow to become excessive. This is called autoregulation of the brain. But that autoregulation is not there in preterm child, because of which when the blood pressure rises, there is likelihood that these vessels will rupture and cause bleed. And that is what happens. And ultrasound is the most effective way of detecting the germinal matrix hemorrhage. Now it occurs very commonly in less than 32 weeks. Greatest risk is less than 30 weeks and less than 1500 grams. The factors that are risk factors for germinal matrix bleed are hypoxia, hypertension, hypercarbia, hypernatremia, rapid volume increase, and pneumothorax. Most will occur within 7 days, and 1/3 will occur within 24 hours. So the optimal screening time to detect all general matrix bleed and hydrocephalus is between 1 to 2 weeks, but actually it will occur still before that. So actually optimal time in the preterm child is still earlier. We will come to that. Now grades of general matrix, these are very simple grades such as given in chlorotic. Grade 1, grade 2, grade 3 and grade 4. Now grade 1 is a subependymal hemorrhage. Now can you tell me where are the frontal horns here? Where is the caudate nucleus? Yes, that is the area that is below that. So here is the area of the caudate nucleus. And in this section we are not able to see the thalamus. But this is the area where the germinal matrix is there, where is the pointer that I am showing, laser pointer. So if you see echogenesis in that area, then you should start suspecting that there is a germinal matrix. This in capital is a echogenic mass. Now, if the hemorrhage doesn't advance, in case it advances, it will go to stage 3, stage 4, grade 3, grade 4. But if it doesn't advance, then as the clot ages, it becomes less echogenic and the center becomes sonolucent. Sonolucent is which color? Black in color. So surrounding will be white, middle there will be black in color. Then you see that this is now resolving. And finally the clot will retract. Necrosis occurs with complete resolution of the hemorrhage, or all of this will be replaced by a necrotic tissue which will be black in color, that is called the porencephalic cyst. So now show me the germinal matrix area here. First show me the caudate nucleus. That is the thalamus. The caudate, yes, that is the caudate nucleus. This is the thalamus, and show me the echogenic area. The groove, yes. So that is the echogenic area that you are able to see. That is a caudothalamic groove. So that is a stage 1 germinal matrix bleed. In the coronal section, can you show? Yes. So on both sides symmetrically, so this is the bilateral germinal matrix bleed. This is in the zooms. As zoomed it, yes, right. Now grade 2. Grade 2 means what? This germinal matrix bleed which has happened now, it goes into the ventricles. So color is hyperechogenic, that means white in color, and sometimes this echogenic hemorrhage will be indistinguishable from the choroid plexus. And similarly, as the clot ages, it will become sonolucent. And now show me the choroid. Yes, that is the bleed there. And show me the ventricle. Yes, that black is the ventricle. Now this is going into the ventricle. It has gone away from, now moved to the second stage. Now stage 3, this is associated with hydrocephalus. This is very obvious. Show me the dilated ventricles. Yes, this is the dilated ventricles. And in the coronal section, they are very obvious now. Third ventricle, temporal horn. Yes. So no need to go to this stage. Great. Okay. Now here what has happened is, show me the choroid plexus here, bleed. Yes. And the occipital horn around it. So here you should actually not see any fluid around it. So what has happened here is that the choroid plexus is now enclosed in the ventricle. Now if you see in the first film, which is a dependent part, right side or the left side of the baby? Here. Which is a dependent part of the head? The right side. Right side. See? And where is the clot? Clot has moved to the right side. Okay. Now I turn the head of the child to the left side and see where the clot has moved now. So this is what is seen when there is a very gross hydrocephalus. The clot moves inside the occipital horn. Then grade 4 is the intraparenchymal bleed. Now show me the choroid plexus here. Yes, and show it. And the bleed, intraparenchymal bleed, will be seen as a echogenic or evolucent? Echogenic means white in color. Okay, now show me any abnormal white pattern you are seeing. Yes. So that is the bleed in the parenchyma. Now these parenchymal bleeds are usually seen in the frontal lobes, frontal or sometimes in the parietal lobes. Nowadays, what the new theory they have proposed is, rather than the grade 4, this is a separate entity, because as the ventricles dilate, they compress upon the vessels that are going towards the cortex. So here there are vessels which are going towards the cortex, and because of this hydrocephalus, the vessels are compressed. The veins are compressed. They are actually venous bleeds. venous drainage does not happen and the bleed occurs. The same thing I do. Now coming to the subarachnoid bleed. There is enlarged, so there is enlarged interhemispheric. The interhemispheric fissure here. Yes, this is center. The center is the interhemispheric fissure, and you can see that there is a abnormal echogenicity in that. So this is a subarachnoid bleed, and there are different sulci. So this is, I have zoomed it. Just pointed out the interhemispheric fissure. Yes. So this is the enlarged interhemispheric fissure. Then coming to the periventricular leukomalacia. Now I told you that this is the watershed area in the PVL is seen in preterm. So there is a periventricular area. So here you can see that this is the periventricular area, and you can see the echogenicity is there. This is the book pictures. My pictures I will show you. And as it advances, it leads to the formation of cystic spaces. Now there are cystic spaces have occurred in the, because there is ischemia, there will be necrosis. Necrosis will be followed by, it will liquefy, and finally it will become dark in the liquid like. So white matter in the arterial border that I have already shown you. Cystic changes are seen late, and ultrasound is best to identify the cystic PVL. It is there, and for the non-cystic PVL, means for earlier stages, MRI is the gold standard. Here you can see this is the patient. You can see the cystic spaces here very near the ventricles. This is a periventricular leukomalacia. And this was the MRI of this patient. So you can see that there is hyperintensity in the periventricular area. Grades I have already told you. So you see the peritragonal blush. Show me the peritragonal blush. No, in the second. Yes, that is correct. That way. So when the choroid plexus. Yes. So you compare the choroid plexus echogenicity with the echogenicity of the peritragonal blush. If the echogenicity is less, then it is grade 0. If it is same, it is 2, grade 1. And if it is more, then it is grade 3. Now, when should be the first scan done? We have seen that it is more common in less than 30 weeks and 30% occur in less than 24. So, first scan in a patient who is a preterm less than 30 to 32 weeks, it should be done within 24 hours. As you go on seeing the patient start improving, you can skip the second or third scans. But if the patient is not doing well because of some reason, say for example, there is a pneumonia, there is a sepsis, or any other problems, bleeds, then you can, patient doesn't keep, then you go on the day 3 or day 7 as well. But the fourth scan at 4 weeks is mandatory because sometimes PVL will be missed on ultrasound and will be caught up later. Of course, if the patient is bound to develop the PVL, there is no way that we can prevent it. We have to prevent it by taking all the usual care, hypothermia, normal electrolytes, normal glucose, sepsis, etc. All that we have to do, we will be doing in all patients as well. But once it has happened, we cannot prevent it. By 4 weeks, we should be able to see the PVL clearly and the ventricular enlargement as well. So, first and fourth scans are mandatory even if your patient is normal, and in between the second and third scans are optional. Now, cerebral edema. Now, what happens in cerebral edema? There is diffuse echogenic brain. So, cerebral edema means what? Fluid. So, fluid goes on accumulating inside the neuronal cells. Because of this, the cells get swollen and they will obliterate the sulci. Those sulci will be poorly defined. And the grey matter white matter differentiation that is normally seen will not be seen properly. Okay, now show me the corpus callosum that we should be seeing, where we should yes. Are we seeing it properly? We are not able to see it properly. Are we able to see the sulci? Normal sulci, we are not able to see the sulci. So this is a patient who has got an abnormal grey matter white matter differentiation. Then you can see that there are some abnormal, for example here, there is a lucency and here there is a hyperechogenicity. So here there is a hyperechogenic, here there is lucency. So these are the abnormal findings that you will see in the brain parenchyma in children. In the third scan, again you see that there is a hyperlucency here and there is an edema here. Can you differentiate between the caudate nucleus thalamus? We are not able to differentiate between the caudate nucleus. and sometimes the edema is too much, then the ventricles are fingers. If they are compressed, then you will not be able to see the ventricles at all. So these are all signs of cerebral edema. Meningitis and ventriculitis. What happens in meningitis is there is echogenicity of the meninges, but sometimes this will not be appreciated, or the ventricular walls. That in ventriculitis. But the disease progresses, then you can see that there is a dilated frontal hall. Show me the frontal halls. Yes, and you can see the echogenicity that there are strands also. So this patient has developed ventriculitis. Echogenic debris will be seen, dilated ventricles are seen, shaggy appearance of ependymal lining. So show me the ependymal lining, this lining of the ventricles is. So this all has become more echogenic, fibrous septae are there, and patient will develop other complications that can develop are subdural empire. Yes. So now this is another case. Now here, this is the area. This is a echo-free space that we are seeing here. Echo-free space. This is usually not seen here. Show me the corpus callosum. Yes. Cavum septum pellucidum. Oh, that is the third one. Okay, that is the cavum septum. Cavum vergi. Cavum vergi. Yes, that is the cavum vergi. Posterior. So below the cavum vergi, you will see a similar structure as if this is fluid filled, and this fluid filled space is normally not seen here. So this appears like a cyst. But this cyst could be something else, whether it is vascular or not, or avascular, that you will be able to know if you put color. Now what has happened here? This is not a simple fluid cyst. This is a vascular structure, and a vascular structure in that particular area that I am showing you is a classical case of vein of Galen malformation. So this is the use of Doppler. Doppler I have not talked as up till now, but this is the last slide. Just I wanted to introduce to you. This is the pericallosal artery, and this is the vein of Galen malformation. So this can be diagnosed in the newborn period as well, just because of this abnormal hypoechoic or a cystic structure that is seen below the cavum vergi. So thank you for the excellent Chairman.
Thank you, sir, for the wonderful talk. For next speaker is Dr. Sriganesh, sir. We will be talking on MRI and neurotech.
After having the basics in neuroanatomy, now we are moving to the neuroimaging specific. I am going to cover the MRI neonatal encephalopathy. Most of the slides will be on the hypoxic ischemic encephalopathy. Along with that, we will also see the MRI patterns in common another neonatal encephalopathy apart from the hypoxic ischemic encephalopathy. So, what are the other causes apart from the hypoxic ischemic encephalopathies that will cause the encephalopathy in the neonatal period that will require the MRI in the neonatal period? And these are infections like encephalitis, meningitis, ventriculitis, metabolic disorders like maple syrup urine disease, methylmalonic acidemia, obviously hypoxic ischemic encephalopathy, hypoglycemia, Kernick teres, vascular causes like acute ischemic stroke, cerebral venous sinus thrombosis, then congenital brain malformations like corpus callosum agenesis, then Zellweger syndrome, Joubert syndrome, and hypomyelination. So, outline of the presentation will be, most of the slides will be on the hypoxic ischemic encephalopathy, identifying the common MRI pattern. We will see the MRI pattern in severe profound asphyxia. We will see the MRI imaging pattern in partial prolonged asphyxia, and we will see the imaging pattern in the preterm babies with the hypoxic ischemic encephalopathy. Apart from the hypoxic ischemic encephalopathy, we will also see the MRI pattern other than hypoxic ischemic encephalopathy, which also cause the neonatal encephalopathy like metabolic disorders, and we will see how MRI is helpful in prognostication the hypoxic ischemic encephalopathy. So starting with the first case, the baby of a full-term emergency LECS in the view of abruptio placenta requiring bag and mask ventilation, intratracheal intubation, having seizures at 18 hours of life, during NICU admission having oliguria and the shock, and having stage 3 HI like picture on the day of life. is the common scenario we are getting in our day-to-day practice in our NIC. And this is the CT scan, as it was the babies on the periphery, the pediatrician did the CT scan there. It is the CT scan and the day of life 10. Just go back again the neuroanatomy and on the CT scan. So this is the normal CT scan, and again this is the happy face. We are looking at the gut side, the happy face, and which structures we will look? We will look the thalamus, and we will look the basal ganglia. We will look the ventricles also. So what are the CT scan changes on day of life in the case of severe profound asphyxia? The baby is having asphyxia on the day of life 1. He is encephalopathic from the day of life 1. So there is involvement of bilateral thalamus as well as the bilateral basal ganglia. Just clearly see, these are thalamus and these are basal ganglia. So in short, what are the structures that are involved in the term baby with sudden and profound asphyxia? The mature neurons that is having high metabolic rate are most vulnerable in the term baby with severe profound asphyxia. And what are these structures? As shown in the CT scan, these are thalamus and these are basal ganglia like the putamen. Other structures also gets affected, but the common structure affected are the thalamus and the basal ganglia, that is putamen. Apart from that, hippocampi, periodontic area, brainstem, internal capsule, they also get affected, but in term baby with severe profound asphyxia, encephalopathy from the day of life 1, the common structure get affected are the thalamus and the basal ganglia. So, what will you look for in the MRI in the near total asphyxia or in the profound asphyxia? So, within 24 hours, look the changes on the T2 weighted images. In 3 to 5 days, the damage will be the maximum, injury will be the maximum. So, in that case, we have to look for the maximum injury. And after 1 to 2 weeks, we have to look for the phallotic area. So these are the MRI changes in the severe profound or the near total asphyxia. So this MRI is reported by the radiologist as the normal MRI. But if you have the clinical scenario, you know the baby is having severe profound asphyxia, abruptio placenta is there, intubated, child is encephalopathic, day of life 1, term baby. We have already seen which structures we want to focus, which structures can be involved, thalami is involved, and the basal ganglia is involved. So you carefully look thalami and the posterior part of the putamen. So if you have the clinical correlation, so always give the proper history to the radiologist. So they will also see where to have to look. So day 1 encephalopathic baby, severe profound asphyxia, initially reported as a normal, but if you have the clinical correlation here and we see with the more focus, there are hyperintensities in the basal ganglia and the as well as the thalamus. So this is the abnormal MRI and not the normal MRI. Similarly, we have to take the diffusion weighted images. On diffusion weighted images, we can get the changes as early as 6 hours. They will be better visualized in between 18 to 24 hours. Remains till for the 5 to 7 days, and after that we will not get the abnormality or signals in the diffusion weighted images, but yes, we can get on the T1 and T2. So always take the diffusion weighted images. That will be helpful to whether it is acute injury or whether it is chronic injury, because they will get the changes till the 5 to 7 days of their life. After that, we will not get any changes on the diffusion weighted images. So what is the importance of plic site? Plic is posterior limb of internal capsule in hypoxic ischemic encephalopathy. So it is the structure that is myelinated at the birth. Okay, so here it is longly labeled. This is T2 and this is T1. Just consider vice versa. This is T1 and this is T2. So posterior limb of internal capsule is the structure that is myelinated at the birth, and this is the posterior limb of internal capsule. Okay. This is the posterior limb of internal capsule. So any structure that is myelinated at the birth on T1, that should be brighter. Okay, so here posterior limb of internal capsule is brighter. On T1, this is T1, it is brighter, and on T2, it is darker. So any structure that is myelinated at birth, just remember the basic rule. That should be bright on the T1. So look at this MRI. So this is definitely T1, CSF is black, and look the posterior limb of internal capsule. This is not brighter, this is hypointense. So this means there is a loss of plic site Okay, so look for the posterior limb of internal capsule. If it is on T1, if it is dark, then there is a loss of Glick sign, and this means there is a severe profound asphyxia or near total asphyxia. It can be detected well at the end of first week, but in severe cases, we can detect the Glick sign as early as within the 24 to 48 hours. Apart from the Glick signs, what are the other brain areas? We have to look for the severe profound asphyxia. I already told. Have to look for the thalamus and have to look for the basal ganglia. Okay, this is another MRI picture with severe profound asphyxia causing the hyperintensities in the thalamus as well as the basal ganglia, as well as there is a loss of Glick sign. Posterior limb of internal capsule on T1, it is dark. It is not a bright. It should be bright in normal baby. So loss of Glick sign. So this kind of MRI picture is of severe profound asphyxia. That is having encephalopathy from day of life 1. So we'll go to the next case. So this is another baby of B, having history of PRON, house feeling like a fast breathing and grunting from the day of life 12 hours, chest X-ray showing pneumonia. At 18 hours, he is having the shock, requiring the inotropic support. Inotropic supports are off from the day of life 3, day of life 4, extubated at the 72 hours, and the baby was lethargic from the day of life 4. So there is a partial prolonged condition. It is not like a previous case. Previous case was everything was hyperactive, starting from the day of life 1. Here it was started from the day of life 12 hours, and they are prolonged till the day of life 4. So this is the case of partial prolonged asphyxia. And this is the CT scan. Again, a peripheral case, they did the CT scan. So what we will see, this is the normal CT scan. You look at the bean-shaped level so that we can get the clear white and grey matter differentiation. Symmetry is the good. And this is the CT scan of that baby on the day of life 6. So what will you see? So there is a hypodensity in the parasagittal region. Okay, grey and white matter differentiation is almost gone. Okay, hypodensity is in the parasagittal region. As already told by the Hirokiru sir, lateral area was supplied by the MCA, lateral. Parasagittal area was supplied by the ACA, and this is in between watershed area. Okay, watershed area. Similarly, posterior cerebral artery supply the posterior area. Then middle cerebral artery supply the lateral area, and there is the hypodensities in the watershed area. So what I want to tell that in prolonged asphyxia, partial prolonged asphyxia, we will get the hypodensities in the watershed areas, and in the severe profound asphyxia, Glick sign, have to see for the Glick sign, thalamus, and the basal ganglia. Similar MRI was done after the CT scan. It was also said that in the watershed area, this is the watershed area, this was supplied by the MCA, this area, and ACA, and this is the in between watershed area. There is an extension of the hyperintensities towards the cortical and subcortical region. Similarly, posteriorly also, posterior cerebral artery, middle cerebral artery, here also watershed area is involved. There is an extension of the hyperintensity towards the cortical and subcortical matter. So in short, in prolonged asphyxia, partial prolonged asphyxia, we will get the changes in the watershed area. In severe profound asphyxia, basal ganglia, thalamus, and the Glick sign. So clinically, in our practice, we have two scenarios. That is near total or profound asphyxia. Second scenario is partial prolonged asphyxia. Okay, emergency situations like abruption placenta, cord prolapse, cardiac arrest in the mother, cardiac arrest post-delivery can cause the near total asphyxia, whereas cord around neck, difficult resuscitation, shock, respiratory distress, sepsis will cause the partial prolonged asphyxia. So it should be clear that where we have to look for the changes. Otherwise, radiologist will report is a normal, as I have seen the first MRI. Okay, so we have seen the two scenarios: severe asphyxia and prolonged asphyxia. Now, third scenario, this is a baby of D, preterm, 29 weeks, LACS. Respiratory distress, surfactant, mechanical ventilator for 3 days, and discharged at the 33 weeks. So, as sir was already told, in preterm, when the area that is vulnerable or that will be damaged with the glial cells, and the glial cells are located around the periventricular area. So, in the preterm, periventricular leukomalacia is the common as the changes seen in the asphyxia. So, let's see, this was the CT on the day of life 15, it is the preterm baby. Okay, there is a clear-cut gray and white matter differentiation anteriorly, but see the posteriorly. There is a loss of gray and white matter differentiation. Okay, periventricular region. So this is the abnormal CT. Similar, this MRI is also repeated as a normal. As we also first think that this is a normal, there is nothing abnormality. But if you see, this is the shape of the ventricles. It's a squaring of the ventricles. This is because of loss of white matter. Okay, and if you have the clinical history that this baby is preterm, okay, he is going to have the injury around the periventricular areas. And if you then see the clearly, there is a squaring of the ventricles because of the loss of white matter, then we will come to know that even the radiologist reported as a normal, this is an abnormal MRI in preterm baby setting. So that's why you should have the good clinical correlation with the radiological correlation. You have to provide good history, not only to the radiologist. I have seen many times for the genetic reports also. Because the history was not going properly provided, so it will come as a variant of unknown significance. Okay, so you have to give a good history to the pathologist, to the radiologist, and towards the genetic report. So similar case at the 14 months, this is the normal CT scan. We all know 2 worms like structure, gray and white matter, ventricles are normal, no any hyper or hypodensity. And this is the 14 months age has come with the global developmental delay, and this CT scan is also reported as the normal, but the child is heavy, the child is preterm, requiring the surfactant, NICU stay, and then we again notice that there is a squaring of ventricles, okay, because of the loss of the white matter. So this is not the normal CT scan, this is also abnormal CT scan in the setting of preterm baby. So in short, preterm baby will have the periventricular leukomalacia, they will have the affection towards the periventricular white matter. This will look like a dilation of the occipital horns of the ventricles, but this is not. This is a pseudohydrocephalus, this is not a true hydrocephalus. As there is a white matter loss, the ventricle size has increased. Okay, so this is again a MRI of a preterm baby because of the white matter loss, periventricular white matter loss, and it will be wrongly taken as an hydrocephalus. Okay, so we should identify true hydrocephalus and the pseudohydrocephalus. If what white matter loss is there, ventricular size will increase, and that is the pseudohydrocephalus. This is again the MRI of the preterm baby. So till now we have seen the 3 scenarios and 3 MRI pattern of the hypoxic ischemic encephalopathy, that is term baby with severe profound asphyxia, partial prolonged asphyxia, and the preterm babies and classic MRI patterns. Now we will see some inborn nerve metabolism that was clinically as well as radiologically that will mimic the HI, hypoxic ischemic encephalopathy. Not only clinically, they will have similar picture as a MRI on the HI also. And for 2 common conditions we have to remember that sulfite oxidase deficiency and molybdenum cofactor deficiency. So look this MRI. This was done on the day of life 12. So born of 2nd degree consanguineous marriage. And if you look the MRI T1 sequence, basal ganglia involvement, posterior limb of internal capsule is dark, that is loss of plexi. So it will be reported as a HI. Okay, HI in the term baby with profound asphyxia. But there is no clear-cut history of the neonatal encephalopathy. So we thought we will go with the genetic testing, and it is turned out to be the molybdenum cofactor deficiency. Another similar condition, sulfite oxidase deficiency. We will have similar clinical as well as radiological picture that will mimic the HI. So the problem is that most of the radiologists don't want to go beyond the HI. Okay, so everything they will report as an HI changes, even if the reason maybe we are not giving the proper history, but we have to look out these 2 conditions. Their clinical picture as well as MRI. This was clear picture of HI in profound asphyxia, loss of plexi, involvement of basal ganglia, involvement of thalami, but history was not of neonatal encephalopathy. So it is a genetic condition like a molybdenum cofactor deficiency. Apart from this HI, what are the other causes that neonate will have encephalopathy from the day of life 1? And these are major vein malformation, polymicrogyria, pachygyria, lissencephaly, schizencephaly, then some genetic conditions like PDH complex deficiency, and obvious HI is also one of the cause for encephalopathy from day of life 1. So we will see this, that is encephalopathy from day of life 1 with 2-3 case scenario. So this is the 3rd degree consanguineous marriage. On day of life 1, he is lethargic, poor feeding, and recurrent episodes of apneas, and on ventilator for 48 hours. Thus, apnea episodes are taken as a seizures and loaded with the multiple anti-seizure medicines, but there is no response to the anti-seizure medicines. Dull looking, poor cry, hypotonia, intermittent apneas, sepsis screen negative, PSL, electrolytes, calcium, neurosonography on day of life, TMS, GCMS, EEG showing diffuse cerebral dysfunction, but CSF, lactate, everything is normal except the EEG. And this is a, just look is respiratory rate is very scary video. The biggest in recurrent apnea is respiratory pattern. Recurrent episodes of apnea, daily multiple episodes, treated as a seizure. So how will you different seizures because of respiratory causes and seizures because of apnea because of respiratory causes and apnea because of seizures? These are loaded with the multiple anti-seizures, thinking that this may be seizures. Heart rate. Heart rate. So apnea because of seizures, there will be tachycardia. Apnea because of respiratory causes or any other causes apart from the seizures, there will be the bradycardia. So this baby is having multiple episodes of apnea daily. Okay, from day of life 1, no response to the anti-seizures. And look at them. Can anybody describe? Yes, very. So this is thoracic molar to their parents. Sorry. This is molar to their parents. Okay. So this is how we have to identify whether the apneas are clinical messages. We have to identify apnea is because of seizures or apnea is because of respiratory pathology. As this was in the brainstem area, which is related with the respiratory and cardiac control, this is the child was having the recurrent apneas. So, encephalopathy, we see the causes from the day of life 1. Now we will give the neonatal encephalopathy on day of life 2 and day of life 3. In India, common causes are hypoglycemia, sepsis, meningitis. Yes, metabolic disorders also come in this group. For hypoglycemia, if they are vulnerable to have the occipital injuries. Okay, hypoglycemia will affect the occipital lobes. This is the classical MRI picture causing the occipital lobe injury in a case of neonatal hypoglycemic brain injury. Similar gliotic areas, MRI done little bit later after 6 months at the age of 1 year, and now they become the gliotic area in the occipital region. So neonatal hypoglycemic brain injury will affect the occipital region. Encephalopathy on day of life 3 and day of life 4, again causes are hypoglycemia, metabolic disorders, viral encephalitis. So we see the case scenario of this group. So this is a 37-weeker, second born of consanguineous marriage, normal perinatal period, on day of life 3 having abnormal movements that are seizures, gradual encephalopathy, respiratory failure from the day of life 12, and having the generalized hypotonia and the sluggish reflexes. And this is the picture diagnosis. Can anybody tell? All the myelinated structures of the brain are very matters, including cerebellum, including thalamus, basal ganglia, and the white matter. So all the myelinated structures of the brain are edematous. Having normal to the day of life 3, having seizures, encephalopathy, respiratory failure, hypotonia. So this is the classic picture of MSUD. Okay, and that is also, we will get some idea from the EEG also, like a comb-like pattern on the EEG. We will get the IEM, comb-like pattern on the EEG, we will get the IEM, and this is having the high lysine level, and this is the case of Mapper serum urine disease. Though the prognosis is poor, but we have to see the classic, if you get this kind of picture. So this is very classic for the MSUD. All the myelinated structures of the brain are edematous. Okay, so another case of similar group, that is encephalopathy from day of life, between day of life 3 and day of life 4. So this is a term baby, one of LACS, 4 kg, died immediately after birth. From the day of life 3, he is dull, lethargic, absolutely normal till the day of life 3, lethargic, poor from the day of life 3, multiple seizures, requiring on-phenobarbital, ventilated for the 36 hours, having edematous skin rash, poor cry, hypotonia, and depressed neonatal reflexes. So what will be the differential? It may be sepsis, meningitis, metabolic, HIV will be there at the last, because till the day of life 3 was absolutely alright. So the first will be the maybe sepsis, meningitis, maybe metabolic, or it can be HIV. But laboratory parameters having thrombocytopenia, rest of calcium, magnesium, RFTs, ammonia was normal. CSF showing inconclusive again, 26 cells, 15% polymorphs, protein is rising to 163, sugar 38, culture steroid, TMS, GCNS is normal. And look out his MRI. Okay, so encephalitis will predominantly affect the gray matter. But here in this MRI picture, white matter is affected. Okay, periventricular region is affected. Corpus callosum is also involved. So this is leukoencephalitis. As encephalitis has involved the white matter, this is labeled as a leukoencephalitis. Otherwise, encephalitis will predominantly affect the gray matter. And this is the similar extensive lesions of the leukoencephalitis. And what are the reasons for leukoencephalitis in the neonates? If you get this kind of MRIs, day 3 baby absolutely alright, seizures, thrombocytopenia, sepsis-like presentation, and this kind of MRI showing the leukoencephalitis. So what will the positive organisms? It may be pericovirus, rotavirus, enterovirus, dengue virus, and the chikungunya. So leukoencephalitis in the neonate. Another organism, apart from this pericovirus, rotavirus, enterovirus, dengue, and chikungunya, that will predominantly affect the white matter. And in the gliotic lesions in the white matter is the Citrobacter meningitis. So MRI is useful not only diagnosing the conditions, it is also useful the diagnosing, finding the etiology also. So this kind of white matter involvement causing the gliotic lesion in early neonatal period, the organisms can be the Citrobacter meningitis. Okay. Till now, we have seen the typical presentation as encephalopathy and various days of life. Now we will see the one case that is having encephalopathy as well as the refractory seizures. And the clinical picture is child is having sparse hypopigmented hair, seborrheic dermatitis. I know everybody has guessed the diagnosis. What is this? Biotin. Yes, we right. Look the biotin level. 0.70. Normal is 4 to 5. Okay. What is the role of biotin in the brain maturation? It will require for the myelination. Biotin is required for the myelination. What MRI findings we will get in the biotinidase deficiency? Again, look the plate. T1 image and look for the plate. What is it? It is dark. It should be brighter. That is the normal myelinated structure at the birth is the plate. That should be brighter on the T1. So this is dark plate, posterior limb on T1. So there is a loss of myelination. Very characteristic MRI seen in the biotinidase deficiency is the loss of myelination. And this is the treatable cause. You should not miss this. A single dose of biotin has reversed all the changes. Seizures has stopped. Baby has improved the developmentally very good. So this should not be missed. Okay. Encephalopathy with seizures, sparse hypopigmented hair, seborrheic dermatitis. Okay. Okay. So what is the role of imaging? Last 4-5 slides. Role of imaging in the neonatal encephalopathy to identify the etiology as well as the nature of insult and the prediction of the outcome, that is the extent of the injury and the pattern of the injury. What is the MRI? This is the most common question we do the MRI in hypoxic ischemic encephalopathy. So maximum injury will be around 3 to 5 days. So the best time to do the MRI is 4 to 7 days. And we should go with the diffusion weighted images. Okay, so how diffusion weighted images will help? We'll tell about whether the particular injury is acute or whether the particular injury is chronic. So for that, we have to do with the diffusion weighted images. It will also helpful in identifying the cause, pattern of the injury, and prognostication. How MRI will help in the prognostication? NICHD, National Institute for the Child Health and the Diseases, has given the classification, MRI classification, that will be helpful in the prognostication. So 0 classification means it's a normal area. Class 1A, it means there is a minimal cerebral lesions without any involvement of basal ganglia thalamus, without any involvement of anterior limb of internal capsule, posterior limb of internal capsule, or no infarct in the watershed area. Only few minimal lesions. Okay, that is 1A. 1B, more extensive cerebral lesions, but still no involvement of basal ganglia, thalamus, anterior limb, posterior limb, and watershed area. 2A, there is involvement of basal ganglia, thalamus, anterior limb of internal capsule, loss of leak sign, watershed infarct, but without any other cerebral lesions. 2B, involvement of the basal ganglia, anterior limb of internal capsule, posterior limb of internal capsule, then watershed areas with additional cerebral lesions, and the 3 is the diffuse cerebral involvement. The outcome will be the poor from the 2A and 2A onwards.
As soon as the thalamus, basal ganglia are gets involved, the outcome will be the poor. So this is how the MRI is not only helpful in the diagnosis, it is also helpful in the prognostication. If you see the MRI where there is involvement of the thalamus, the baby will have the severe dystonia because the thalamus and basal ganglia are related with the involuntary movements, and that will have the poor outcome. So 2-3 years back in Lancet, the article was published on the role of MR spectroscopy in prognostication of the neonatal encephalopathy. They have studied. So they have studied approximately 230 neonates with the neonatal encephalopathy. Okay, and what they have studied, what is the role of MR spectroscopy in predicting the outcome in the neonatal encephalopathy? And they found that the neonates with low and they have found that the neonates will have low levels of NNA, N-acetyl aspartate peak in the thalamus are associated with the poor outcome at the age of 2 years. Not only peak, they have also studied the other parameters also. What is the neurological examination at the time of the discharge? What will be the, whether there is involvement of basal ganglia and thalami, whether there is a, what about the Plick sign? And they also found similarly that if there is a abnormal neurological examination at the time of discharge, basal ganglia involvement, thalamus involvement, loss of Plick sign, they are associated with the poor outcome. I think I should stop here. So remember that if there is involvement of basal ganglia, thalamus, it is associated with the poor outcome. That will help us while counseling the patient. What will going to happen in the future? He is going to have severe involuntary movements, dystonia, seizures, severe developmental delay. Class 1A, class 1B, there are no involvement of basal ganglia and the thalamus. So outcome will be the good. If it is not like that, every baby with the neonatal encephalopathy will have the bad outcome. Because most of the time resident will come still. Now nothing will going to happen, the baby will have the seizures, developmental delay, and that will create some social issues also. I have seen the one patient who has do the suicide because family has cursed her because of her, all these things happen, and then later in the future the baby is doing well. It is not that all the babies with the neonatal encephalopathy will have the bad outcome. It will depends on the MRI finding. Where is the MRI is getting affected? So this is the MR spectroscopy published in the Lancet Neurology 3-4 years back. 200 children are studied and found that the children who had low peak of NNA in the thalamic region was associated with the poor outcome. The final. Thank you.
Thank you, Ganesh sir. Next talk will be by Dr. Sahil sir on MRI changes in common pediatric problem.
The DWI imaging, there is on DWI imaging there is this hyperintensity which is seen, and also on SWI imaging you can see that there is blooming suggestive of bleed. So this history and this MRI correlation is typically associated with HSV encephalitis. So how this HSV encephalitis presents. Another case, 2-year-old male child presenting with acute febrile encephalopathy, had cough and cold before, which was not very significant. Frequent seizures, when came, GCS was poor, was mechanically ventilated. CSF showed few cells, lymphocytic predominant, high proteins, and this is the MRI finding that is typically there. So this is an axial T2-weighted sequencing, which is showing hyperintensities predominantly affecting the right temporal region, the pons, and also the thalamus. So there is this patchy involvement which is seen involving the caudate nucleus, the thalamus, and the bilaterally symmetrical but a little bit patchy. More involving also the white matter. So it was kept as a case of Japanese B encephalitis. So typically this type of MRI is typically seen in Japanese B encephalitis. Next case, 12-year-old female, acute febrile enceph, had vomiting, pain in abdomen, headache, thrombocytopenia, NS1 was positive. Okay. CSF showed few cells, 67 cells. This is a typical MRI feature that is associated with dengue encephalitis. What is there? You can see that there is this T2 hyperintensities which is seen in the thalamus, also in the pons and slightly in the midbrain. The cerebellum also seems to be involved. Along with that, there is a restricted diffusion. Along with that, ADC darkening is present, suggestive of cytotoxic edema. And also you can see that there is a T2 hypointensity which is seen, probably leading that there is some cerebellar bleed also present. Also very significant, this is the bilateral thalamus which is swollen, which is a flare axial image showing hyperintensities. This is typical of a MRI which is seen in dengue encephalitis. Another case, 9-year-old female with acute febrile encephalopathy, had pleomorphic rash, had left-sided weakness with hemidystonia. Correct. So we all know the diagnosis, it is varicella. Okay. What are the CNS manifestations of varicella? Correct. On doing MRI, there was an axial flare which is showing acute infarct. Basically, there is hyperintensities in the right posterior putamen, and this is the MRA which is showing narrowing of the supraclinoid, internal carotid, and the proximal and the middle cerebral arteries. Right. That's a typical varicella mediated angiitis which was seen in this child. Correct. So this is a 2-month-old male child, came with multiple episodes of seizures, had on examination had microcephaly. CSF was done because this was the clinical picture of it. You can see the large head, along with that sunset sign was present. So clinical suspicion of hydrocephalus was kept. CSF was done, high cell counts, and CSF and blood cultures were done, which was S. typhi positive. S. typhi is very unusual, but in this scenario, what had happened is the mother was giving top feed and she was making the milk with tap water. So that's why she was not able to feed the child very well, and the child ended up in severe hydrocephalus. This is an axial flare image which showing multiple entrapments, multiple ventriculitis, hydrocephalus, severe midline shift, along with that white matter loss, and also this pus which is collected here. The same child sagittal image, T1 sagittal, it shows severe dilated lateral ventricle and third ventricle, and fourth ventricle is obliterated. So this is typically caused due to Salmonella typhi. We treated the child, gave 6 weeks of antibiotics. Now the child is doing very well. This is another case, a 10-year-old male child. He came with complaints of one episode of focal seizures. Correct. Birth history, developmental history, perinatal history was completely normal. When we did his MRI, it showed this. So it is a single cyst which is present in the right parietal region. This is a T2 image which is showing hyperintense lesion. Along with that, there is a hyperintense swelling, which is probably due to edematous swelling, which is present. On T1, there is T1 hypointensity, which is there. This is flare, which is showing hypointense, along with the hyperintensity around the lesion, which is probably suggestive of an occupying lesion. When we did a contrast of it, it was showing a proper link enhancing lesion. So this was a diagnosis that we had kept. Only one cyst, no midline shift, no nothing. So we had kept a diagnosis of NCC. We gave him albendazole and steroid. Now he's doing very well. He will come for a follow-up MRI soon. Okay, this is a 10-day-old neonate. I'm sure Sir and also Sri Ganesh Patil sir also covered this case. This is one thing which we had seen a recent case. This is a 10-day-old neonate, normal birth history. On day 10, he came with multiple episodes of unprovoked seizures. So there was no hypoglycemia or anything, no fever or anything. CSF studies were normal. CRP was raised. So we thought of initially there is a sepsis component associated with it. So we went ahead with the MRI because the child had a prolonged neonatal encephalopathy. And this is the typical MRI feature that we saw. Only the white matter is seen to be affected. This is the parietal white matter. This is the parieto-occipital white matter, which is seen, and it is showing significant restricted diffusion involving both symmetrical parieto-occipital region, right? But since the sugars were normal, and also it is involving the thalamus, it is a typical finding which is seen in parvovirus. We went back in the literature, it was reported outside as hypoxic ischemic encephalopathy. So that's why we always say, don't go with the reports. When you get an MRI, when you're in doubt, go and search the literature of something in this sort, you will understand it. Now, since I was there, I could easily tell, and it's a very easy learning case. We immediately got to know it was a parvovirus. The child now is doing very well, has been discharged, no neurodeficit or as such. But it is a typical MRI feature which is seen in parvovirus encephalitis presenting in a neonate. Coming to basics, so tuberculoma versus NCC, right? So how will you distinguish it? So first are the few pointers. So first is appearance, more than 2 centimeters, irregular, thick and huge perilesional edema with midline shift, with MRI showing lipid peak. Always think that it is a tubercular in origin, correct? On the contrary, neurocysticercosis will be smaller lesions, not multiple enough. They will not cause midline shift, and there will be no lipid peak present on MRS. Always think that it is a neurocysticercosis, and based on that, if you do SWA imaging also or a CT scan, you will see this calcifications in between. That is the calcified stage, the stage 4 of neurocysticercosis. That can give us an idea. Coming to the para-infectious causes, this is a 6-year-old female with acute febrile encephalopathy. She had rapid deterioration of GTCS, multiple seizures. Her SGOT-PT was through the roof. Ammonia was normal, CSF was normal. Okay. This is the typical MRI that we got in this child, correct? So here there is this 3 images are present. The first is a T2-weighted axial image showing bilateral thalamic involvement, or in all of the above. But there is a flare as well as a DWI image. So this typical thing is known as trilaminar sign, which is seen in ENaC. So trilaminar what? So these 3 rings, first, second and third. So this is nothing known as trilaminar sign, correct, which is seen in ENaC. Okay, on further thing on SWA imaging that you can see that the internal red, what I marked, is showing hemorrhage. So acute necrotizing encephalopathy of childhood. It is a very common thing that you get. How will you understand a child who has had, was admitted for acute viral encephalitis, sudden deterioration, SGOT-PT goes through the roof, consciousness deteriorates, well-doing child suddenly becomes altered consciousness, goes on mechanical ventilation. Always think of ENaC. ENaC has a very poor prognosis as compared to other features. Okay, so this is a 23-month-old baby, normal developmental history, birth history and developmental history, had fevers 4 days prior to admission and had 1 episode of focal status. Child had a 30-minute of status. So we managed as a case of acute febrile encephalopathy. When we did a bedside EEG of the child, it showed multiple right-sided high amplitude spike and polyspike wave discharges. And being on this typical spike polyspike wave discharges, then we thought of viral encephalitis in the child. We had done CSF, which was normal. We had sent for CSF culture, which came out to be normal. Then we thought of the possibility being of fires. Correct. So interleukin 6 was sent to this child, which was very raised. We started on tocilizumab. Gradually the child improved, was on mechanical ventilation. When we did the MRI of the child, we confirmed the diagnosis of fires because there was this insular hyperintensity. So this is axial flare, which is showing hyperintensity along the insular cortex, which is typically seen. It is not restricted diffusion, neither there is ADC correlation. So this was an case which was called fires. So fires is febrile related status epilepticus. So now NORS, fires, these terms have been coming up. Previously they used to be left out that nothing can be done for this child, but no. We were able to start lacosamide, intravenous midas drip, then we converted into lorazepam, and finally we got the seizure control. Right. This is a 3.5-year-old female, normal perinatal developmental history. Okay, she came with 3 episodes of focal seizures, which were left-sided in onset, and altered consciousness. Bedside EEG, which we had done, which was suggestive of encephalopathy. CSF was done, which was normal. Culture also came out to be normal. Then, when she was weaned off from the critical phase, we did her MRI, and her MRI showed multiple white matter as well as gray matter involving fluffy shadows. See, the cortex is also involved, the white matter is also involved. So this is a flare, and it shows hyperintensity involving the white matter, the gray matter, the white matter, and everything. Similarly, this is flare. This is the DWI imaging showing restricted diffusion and corresponding darkening of the ADC. So we came to a conclusion that this is a cytotoxic edema. It was reported outside to be as encephalitis, but when you see the child was doing very well. So we thought of it could be something other than that. Then we went ahead and we sent her MOG and NMO, which came out to be negative. Then we thought of it could be EDEM. We started the child on methylprednisolone, and after that the child tremendously improved, and hence we put a diagnosis of acute demyelinating encephalomyelitis in this child. Correct. This is another case, 13-year-old female came with complaints of sudden onset upper limb and lower limb weakness in sedate. Vitals were stable. On examination, power was reduced 3/5. When we did her MRI, okay, so this is the MRI, correct, and she had some visual issues or something, and this worsened in heat or summer season that they typically said, correct. So this is a flare image which is showing hyperintensities in the white matter. Only white matter is involved. Typical margination is also seen. Same on the restricted diffusion showing on the DWI, also showing darkening on the ADC, and this is the clue. So this is Stephen weighted imaging which shows same dark black holes you can see, but this is a typical black holes which are typically seen. So CSF was done, which was normal. So considering the fact that probably she had a vascular insult, we did an MRA which was completely normal. Then we went ahead with CSF, which was normal. Then we did CSF oligoclonal bands, typically which came out with positive. Hence, the child turned out to be multiple sclerosis. We started the child on methylprednisolone initially, and now she's doing very well. Okay. 7-year-old male child came with complaints of fever followed by sudden onset weakness of lower limb, which is non-progressive. Loss of gallbladder function is there. No seizures, no encephalopathies, no visual issues. So now here the localization is clearly the spinal cord, right? There is non-progressive paraplegia which is present. CSF was normal, OCBs were sent normal. In lower limb power was 1/5, and DTRs were absent. Good respiration function as such. The sero status was negative. We did an MRI. Can somebody tell me what is on the MRI? Can somebody tell what is this? Correct. So this is longitudinally extensive transverse myelitis. Right. So when this child came to us, he had a lower limb weakness. When we did his MRI, there was gallbladder loss localized to the spinal cord. There is this longitudinally extensive transverse myelitis. We did an MRI sagittal view, which shows that there is this T2 hyperintensities, which is seen in 2 spots, basically in the upper cord as well as in the lower cord, which caused all the symptoms. We started the child on methylprednisolone and kept the diagnosis as transverse myelitis. We had done a brain imaging also, which was completely normal. We had to do it because we had sent NMO, MOG, because it's all the demyelination picture. If you see, everything comes into now they have coupled everything. So we had to rule out optic atrophy, we had to rule out EDEM and all those other things. Okay, coming to metabolic causes. So this is a child, an infant, came with complaints of delayed development of achievement, milestone hyperpigmentation, knuckle hyperpigmentation, regression of milestones. On examination, low B12, low hemoglobin, high MCV, low retic. So we kept a diagnosis of infantile tremor syndrome. This was the MRI which was done of the child, which is showing significant cortical atrophy. And subsequently, the child was started on B12, and now the child is gaining milestones. And you can see the child is alert, active. Hairs have been changed. The malnutrition part has been reversed. And significantly, the MRI changes have also been reversed in this child. What was there previously, now that has been reversed. So it was kept as infantile tremor syndrome. This is another recent case that we have admitted here. This also child is an infant child, came with similar complaints, hyperpigmentation, his hemoglobin was low, MCV was high, RDW was high, retic count was low. So probably we thought we couldn't do vitamin B12 in this child, but we did ahead and go his MRI. So same case, similar. See this typical cortical atrophy. So this is a T2 weighted sequencing which is showing so much of cortical atrophy, and this is T1 and significant white matter loss. We have started the child on same on the coronal images. We have started the child on B12. Now the child has been gaining milestones. So let's see how the prognosis works. But this is how you should always have a clinical suspicion and always do MRI in a child of infantile tremor syndrome. Okay, a 7-year-old female, normal. Non-consanguineous marriage came with complaints of inappropriate smile, involuntary movements of the upper limbs, and also there was no seizures, no jaundice, birth history was normal, and on examination there was dystonia and choreoform movements of the limbs, and DTS were brisk. Correct. We did a normal workup which was completely normal. Then we did an eye examination of the child which shows KF ring. And then it turned out to be, we did a serum ceruloplasmin level which was very low, and it turned out to be Wilson's. Correct. So we went ahead with MRI, and this is showing, this is a flare, this is a T2 image which is showing hyperintensities in the both of the caudate as well as lobus pallidus. Nucleus corpus striatum is involved here, and significantly there is hyperintensity also seen on T1. So we went ahead and we did a genetic testing in this child, and it turned out to be Wilson's disease. Correct. So why this is important? Early diagnosis, early thing. We started the child on early chelation. Now the child is doing very well as compared to before. Diet and chelation can be helpful in Wilson's disease. This is another child, a 3-year-old female. So second degree consanguineous marriage, progressive dystonia, had global developmental delay, but now came with complaints of developmental regression, which is both motor as well as mental regression. On examination, there is microcephaly, dystonia in all limbs. We did our MRI. Can somebody explain what is this? What has happened here? What part of brain is that? Considering the part there is a dystonia. Basal ganglia, correct. So what has happened here is that the basal ganglia has got liquefactive necrosis and that form and cystic changes. It is showing the same CSF signaling as that of the CSF. Correct. When you see the flare images of the same, you can see that there is flare hyperintensity involving the bilateral globus pallidus and putamen. Correct. So this child was later kept as a diagnosis of Leak's disease, Leak syndrome. We could not do genetic testing for this child because of the monetary issues, but I think the child has succumbed or something when the mother came back. Progressive dystonia did not respond to any medications gradually, and what gave us a clue that it was a secondary consanguineous progressive dystonia, developmental regression. So always think that there is some gray matter neurodegenerative disorder. Always keep a mind and do an MRI. Okay. Vascular causes. This is an interesting case. Yeah. So 9-month-old male child had acute gastroenteritis. He was doing very well. He was about to be discharged. Suddenly he had multiple episodes of focal seizures involving the right focal seizures. And then when he was weaned off from the seizure, that time he had hemi-neglect along with right hemiparesis. So we went ahead and we did his MRI. Can somebody tell me what is this? Okay, so this is a flare image which is showing gliosis involving the left region, basically the MCA territory. This is the DWI sequencing which is showing restricted diffusion, and also that this is the corresponding ADC darkening. If you see his MR angiography, it showed complete absence of flow in the left MCA, and he presented with such a complaint. He was started on aspirin. We did his genetic workup for protein C, protein S deficiency, antithrombin 3, which was also negative in this child. So we continued aspirin for this child, and this child is gaining milestone on physiotherapy. But still, there is some hemi neglect is present, and hemiparesis is also there. Okay, this is a 17-year-old male child. He came with acute onset headache, giddiness, and vomiting. Had cerebellar signs, had nystagmus. Okay, so whenever you have a child presenting with giddiness, vomiting, had cerebellar signs, which was previously doing well, no issues, and you get such an MRI. So this is cerebellum. This is a DWI, which is showing hyperintensity involving both of the cerebellum gray matter as well as the white matter, and there is corresponding darkening on ADC. Always go for MRI neck vessels properly, because sometimes they might be missed. So this is an MRA. TOF is time of flight. It's a sequence basically. So basically this is the basilar vein which is showing narrowing, and also there is vertebral artery narrowing. So always when are you suspecting a child of posterior fossa stroke, always ask the radiologist to have a proper dedicated MRA neck vessels and posterior vessels, so that you come to a clear diagnosis. Sometimes we miss it completely, we may miss the diagnosis. Okay. So this is another case. 1 year old was admitted in as a case of acute gastroenteritis. After a few days, the father was very happy that the child has been discharged. As soon as the child discharged, went home, had multiple episodes of right focal seizures, and had altered sensorium. When the child came to us, we had done all the workup. Sodium, potassium, maybe hypoglycemic or some electrolytic imbalance must have been caused, but no, it was nothing like that. And we went ahead with MRI of this child. It was showing this hyperintensities along the flare, and also this restricted diffusion imaging which was seen. So this is a typical image which is seen. So probably, and this darkening which is seen is probably bleed. So the child had bled also. Then we went ahead with MRA and MRV. So so this is the SWI sequencing, which is showing blooming, right? The blooming SWI sequencing, which is showing blooming of the bleed. So signifies that there has been some intracranial bleed. So we went with MRA, which was completely normal. But when we did an MRV, we could see that the sagittal sinus had thrombus in that. So this was a case of sagittal sinus thrombophlebitis. And the main presenting feature was of altered sensorium, multiple right focal seizures with altered sensorium, improving child, sudden onset. If you have anything, just don't stand like MRA, yes, we have done that. Considering the fact that you have to go with MRV and think on the lines of it could be a venous infarct or a venous stroke also. Okay. This 1 year old child had come with paucity of movements of right upper limb and lower limb after a trivial fall. This child, infant, had a trivial fall, not that big one, just a trivial fall, and after that he came with complaints of not moving his right upper and lower limb. No loss of consciousness, no seizures, no bleed, no cranial palsy, fundus was normal, stroke workup which we had done normal, and we did an MRI, correct. So the first image is an axial CT scan which is showing bilateral calcification, and the next is this lying tram track calcification, not tram track but lying calcification, also known as mineralizing angiopathy of lenticular striatal branches. Now, when you have a child who has had an episode of neuro deficit, there was this showing this this left-sided T2 hyperintensities. Along with that, there was SWI brightening, restricted diffusion, and ADC darkening. Always do a CT brain. So this was the first picture that we got. After which we did a CT scan and showed mineralizing angiopathy of lenticular striatal branch. Now, why this is important? There is something known as mineralizing angiopathy of lenticular striatal branches, which has a very good prognosis. Later on, the child regained all the functions normally. So, what it is being said by the thing that you can omit few restrictions, few tests. It has excellent prognosis. You can just cover up and you can make it forward. Okay. 11-year-old child with multiple episodes of febrile seizures, right? Birth history was normal, family history, development was normal, but family history, uncle had epilepsy and had stiffening of both the arms and leg, which was progressive in nature. the mother said, and also gradually involves the upper limb. Initially, the lower limb was involved, gradually, the upper limb were involved. So, probably you understand by the term that there is some white matter abnormality in this child, definitely. On examination, when we went ahead, we saw cognitive decline, there was hyperpigmentation and spasticity in the child. DTRs were brisk. Correct. When we did this MRI, it was showing this hyperintensity, symmetrical, involving predominantly the white matter in the posterior occipital region, and also the splenium of the corpus callosum was also involved. Right. So considering that the family history, hyperpigmentation, we came to a diagnosis that it is a leukodystrophy and it is probably X-linked, so we came out to be Alexander's X-linked adrenoleukodystrophy. 4-year-old child came with global developmental delay and had progressive spasticity in all limbs. Clues here is progressive spasticity, DTRs were brisk, and macrocephaly. When we went ahead with MRI, we saw 3 main features that clear-cut gave us the diagnosis. First is that there is this T2 hyperintensity which is seen. For a 4-year-old, this T2 hyperintensities are very abnormal, which is suggestive of leukodystrophy. First thing. Next thing, there was this restricted diffusion which was seen. Also, and there was this NAA peak. Right? So MRS. This is an MRS which was showing high NAA peak. So the diagnosis was Canavan's disease based on the clinical features. We didn't go ahead with genetic testing in this child. Correct. This is another 1.4-year-old male child, second degree consanguineous marriage, progressive spasticity, regression of milestones, motor as well as mental, had optic atrophy, global developmental delay, and an episode of seizure. So when you have neurodegenerative disorders with spasticity, always think of a white matter neurodegenerative disorder. Correct. After which we had optic atrophy, seizures, and microcephaly, and spasticity in all limbs. We did his MRI, and it's showing hyperintensities in both of the symmetrical white matter hyperintensities on T1, on T2 images, and we went ahead with significantly. This child was not of diagnosis, he was evaluated elsewhere for metachromatic leukodystrophy, Alexander's, but the age is not fitting in it, he's just 1.4-year-old. So in this age group, rather a Fabry's disease is something which is rather fits in this child. So that child eventually succumbed, but the father was able to get a diagnosis. Now he can further plan a further pregnancy if he's planning to have fun for the child. So the other diagnosis is basically, this is a 7-year-old female child, birth history is normal, and since around 3 years of age, 3 years back, she's been getting multiple episodes of seizure. It's very interesting seizure, the mother describes it very beautifully. The child has an aura of getting a seizure, gets suddenly scared, she runs to the mother, she holds her, and then followed by that, has a deviation of eye to the left side, and has a generalized tonic posturing. Right. So this is a typical onset of how a focal onset seizure presents. She gets an aura of frightening, then runs to the mother, then holds her, and then she has a tonic posturing and deviation of eye to left side. So the significant history here is that the child has had frightening before seizure, indicates that there is a temporal lobe involvement. When we did the MRI of the child, this is what you can see. This is a focal cortical dysplasia. How will you compare? See this, the right sided as well as the left side. This is left sided and right sided. See this, the thick cortex that you can see I have marked in between these arrows. Right, so this is a thick cortex. See, there is no white matter. There is white matter here, there is no white matter here. Right, so this is a thick cortex and it came out to be focal cortical dysplasia, ideal candidate for surgical evaluation or surgical therapy. But now since we have started the child on Levera, the child is doing very well, did not have any further episodes of seizures. Another child, same 6-year-old male child, very normal development, birth, family history, only one episode of focal seizures ever that he had. No cognitive or behavioral issues, no neurodeficit. Correct. And this is this MR flare which is showing hyperintensities in the parieto-occipital region, and it was turned out to be focal cortical dysplasia. Now, since he did not have any fever, we had done this also. We had wanted to see if there is another pathology. We did an MRI contrast also, which showed no contrast enhancement, and it turned out to be focal cortical dysplasia, and the child is doing very well. This is another case of remote symptomatic epilepsy when the child comes. an 11-year-old child, multiple episodes of seizures, focal seizures, right? Focal seizures since 2 years. Birth history, development history was normal, no neurodeficit, was started on Levera. You can see that was some probable perinatal insult that he had in the left frontal region, and now that has undergone encephalocystic changes, which is showing same signals as CSF. So this was the seizure focus. Is another ideal candidate for doing surgical management. This is one child who had come with multiple such episodes. Can somebody tell me what is this? Huh? Infantile spasms, correct. So infantile spasms. So such multiple episodes of spasms were there when we did the EEG of the child, which showed multiple hips arrhythmia. Right. So the diagnosis is typical West syndrome. Right. And when we did the MRI of the child, you can see that there was very pachygyria. There was no sulci which were seen. This is the second child that I'm seeing with pachygyria. This is Alisencephaly. We could not do his MRI, which was we could not do his genetic as the parents were not willing for it. This is another similar case that we had 1-year-old global developmental delay, primary microcephaly. So whenever you have a case of primary microcephaly, always go for MRI, which you will have some sort of cortical malformations in it. See this, there is hardly few sulcations are seen. This is a T1 weighted image and T2 weighted image. Hardly sulcations are seen anywhere. So this was clear-cut diagnosis of mesencephaly. Correct. It's a very interesting case, last two cases. This is a very interesting case. This is a 10-day-old male child. Okay, what is this? Caffeine spots. Caffeine spots are much more of hyperintense. Ash leaf, correct. So this child had ash leaf macules all over the body, right? And antenatal USG was done, which was suggestive of rhabdomyoma. So what is the diagnosis? The diagnosis? Tuberous sclerosis. Correct. So when we did an MRI of this child, a newborn, a 10-day-old, when we did MRI, you could clearly see that there is this hypointense lesion. What is this? This is a T2 weighted sequencing, and it showed periventricular hyperintense, which is present here. Can someone tell me what is this? What is SEGA? Subependymal giant cell astrocytomas, correct. So the child had that, correct. And then this is corresponding hypointensity, which is seen on T1 weighted imaging. And also there was this cortical tubers which were also present in this child. So the diagnosis was tuberous sclerosis. Probably it has present so rapidly, so type 1 is more likely to be present. We could not do genetic testing of this child. Okay. So I think I've written the diagnosis there. Okay, so this child has come with multiple caffeolate spots. So this is how a caffeolate spot would look. Much like the name comes when you have a coffee spilled on a white sheet of paper. That's how caffeolate comes from French word. So this is how they will look, the darkening on spots. This was the child who came to me, and his mother also had multiple neurofibromas. And when we did his MRI, there is something known as very non-specific hyperintensities which were seen in cerebellar white matter, which were seen in basal ganglia, which was seen in thalamus, which was seen in insular cortex. So this is nothing but FASI. So what does FASI stands for? Foci of abnormal intensity. So it's typically seen. So what is the clinical correlation? That these FASIs may turn into neurofibromas and then may cause all the other problems. Apart from the neurodevelopmental learning and disability in the child, FASIs are known to cause tumor formation in this child. Thank you.
All right. Thank you very much, Sahil, for elaborating the different cases. Now, the last lecture by Dr. Nakade sir. We know that last Sunday only I have heard this mnemonic that hungry brain is angry brain. So I request Dr. Nakate sir to have a few words about his topic, that is rabies vaccination. Thank you, sir. Otherwise, these people will not come in for the next my CME. So I will have reduction in the number only.
Yeah.
Thank you so much.
Definitely, I will not come in between your hypoglycemia. That to be corrected, and because hypoglycemia is always dangerous, as we pediatricians know. So again, the other, as it is a sponsor CME, as I told you, I spoke on typhoid vaccine. Now I'm going to talk on the rabies vaccine. Though we are pediatricians, and definitely this rabies vaccinations comes to us only because there are a lot of pet dogs as well as stray dogs issues and multiple animal bites and all that. So we have taken this as a vaccine, important vaccine. So we'll be seeing the details of incidence of the or the problem of the dog bite or the animal bites, and then about vaccines, and then how the clinical presentation. So it's a zoonotic disease of warm blood animals. The rabies is a vaccine preventable disease definitely, but once the rabies is there, it is 100% death. So there is no cure, no treatment as far as rabies is concerned. So only treatment or the only modality of treatment available for rabies is the vaccination, and which is definitely proven vaccines since last so many years. So on an average, there are around 60,000 deaths annually, and up to 95% of the deaths are the bites are mainly because of the dogs. So, and the more commonest animals that are the rabies spreads is mainly dogs, wild cats, bats, jackals, wolves, horse, like that. And mainly the basically, in spite of the bites or scratches or that, mainly the saliva is the infectious agent or infectious thing that has to be considered. So rabies virus belongs to the family of Rhabdovirin and genus Lysis and serotype 1 is there. So it is a bullet shape. This is all details of the virus. Then it is mainly the RNA material. So mainly the pathogenesis, mainly it is affecting the neuronal cells or the nerve cells. And because of this rabies, the incubation period of rabies is too much. That is it varies from 3 months to years together. So there may be some history of past history of 7 years, 8 years, 10 years like that. And later on in the childhood there is some bite or leak to the wound, and the patient later in the adulthood can present with the rabies. So as the incubation is large, the only treatment that is we can use a vaccine. So most important this is that most common animals that are transmitting the rabies is mainly the dogs. The other are cats, monkeys, cattle, then moose, then foxes, wolves, and sheep and goat. These are then deers, pigs, donkeys, horse, camels. These are the occasional animals, but and there's bats and rodents are there. They are there, but they are not being reported. So most of times we come across mainly the dogs as well as cats, because there nowadays so many people are having a pet animal as a cat as well. And again in the periphery, sometimes we can get the rodent bites or the rat bites also. So rats, especially they are not being reported rats, but some varieties of the rodents they are there. They can be injurious or they can transmit the rabies disease. So we have to consider the type of bite, and then we can give as a pre-exposure prophylaxis for these rodent bites also. So symptoms, they are vague symptoms. They can be mild symptoms, or the patient can directly come as a very bad shape. So inability to sleep, insomnia, anxiety, confusion, slight or partial paralysis, hyperacidity, hyperactivity, hydrophobia. This is the classical feature of rabies. That is, even if the sound of the water also can cause the agitation, and patient can be rowdy and those things. Then being easily agitated, hypersalivation, and difficulty in swallowing. So India comes in the endemic zone of this rabies. I mentioned especially it is all over the globe, and 40% of the children under the 15 years of age are having history of rabies or dog bites also. So in India, 20,000 deaths occur every year due to rabies, and 96% are mainly because of the dog bites. So this is the incidence, or this is the intensity of the problem. So, so India comes in the hyperendemic area. It can attack all groups of age groups. When it is 100% mortality, I mentioned, there is no treatment. Then estimated dog population in India is 27 million, and day by day it is increasing. Then shortage of rabies vaccine in the healthcare center is one of the reasons why we are getting rabies more and more. Then annual number of person days lost days lost is the 38 millions, and is present throughout the year. There is no any seasonal variation for this. So this is one of the vaccines from the Bharat Biotech, that is Indirap. It is a rabies vaccine purified inactivated lyophilized vaccine, and it is inactivation is by the beta proteolactin. Category it belongs to the active immunization for the children as well as adults. Shelf life is 3 years, and the storage is in between 2 to 8 days. So, as we all know, the pre-exposure prophylaxis and the post-exposure prophylaxis, there is major difference in the intramuscular and intradermal. The pre-exposure prophylaxis is 0, 7, 28, and booster dose at the age of 1 year, and booster dose after 5 years. And intradermal, basically the dose is 0.1 ml, and it has to be given for 2 injections at 2 different sizes, and it is 0, 7, and 28. So it is to be total 8 doses, and 1 year is the booster dose. And the post-exposure, that is 0, 3, 7, 14, 28, and optional is the 90 days dose. And for again intradermal, it is again 8 doses, that is 2 doses to 0.1 ml, and to different areas, that is delta region. So it is total around 8 doses. So categorization of the bites, mainly that is again depending on the grade 1 of category 1, category 2, and category 3. So only touching or just licking or just this thing, that comes into the stage 1 or category 1. So actually there is no vaccination recommended or this thing, and only treatment is the washing of the skin surface. But definitely if the lacerated or the injured or the cut wounds are there, there is blood contact, and that part has been leaked, then it comes to the category 2. Then second is the niggling of the uncovered skin, minor scratches that come in category 2, and again they require definite cleaning, washing, and immediate vaccination. Third is the category 3, then again single or multiple transferable bites or scratches, contamination of the mucous membranes or the broken skin with saliva from the animal's beak, exposure due to direct contact, that comes in category 3. So all this requires wound washing immediate, then administration of both immunoglobulin as well as vaccine. And special comment on the bites. Usually when there is multiple bites or there are deep bites, usually the suturing is required sometimes at some sites. The usually preferably suturing is not at all allowed, but if the deep wounds are there, bleeding is profuse, you can go for the secondary suturing. And but before that, we have to inject local immunoglobulin at the local site maximum, and then after that 24 hours to 48 hours we can go for the suturing, secondary suturing, that is. So, and one more comment on this. Suppose most of the times I have seen so many patients that because of these pets and all that. So last year we have just completed the rabies vaccination because the child had a dog bite, and again after 1 year the child has again got the bite or some scratch or leakage. So in that cases particularly, if it is within 24, that is 12 months, then there is no need to repeat the vaccination. But if it is after in between the 1 to 3 years of age, you can go for again 3 doses of prophylaxis. So that is recommended. And if it is again, you can go for, if it is within 3 years, it is only 1 dose. But if it is more than 5 years, you have to go for the 3 dose prophylaxis. So particularly this vaccine has been studied in so many countries, and the safety has been more established, and basically it is a recommendation dose is 0.5 ml intramuscularly, and all types of category 2 and category 3 are recommended for this. And there are been given different clinical studies at phase 2, phase 3. Definite there is positive evidence that it helps, and its availability, the antibody titer is within expected reach. Basically the antibody titer after exposure or any vaccination should be more than 0.5 ml, 0.5 international units per ml. And this is very taken into care when we are in the pre-exposed part of the animal people working in the animal husbandry and all that. So they are more requiring for the pre-exposure prophylaxis. So these are the different trials and different results for the particular study of this and comparison of these multiple vaccines. So I will not go into details. So coming to this important this thing. So why it is superior over water various advantage, one is high virulence and more potent than others. Then chromatographically purified is there. Then it has a 100% protection against the rabies in multi-center trials. In absence of the neurological adverse reactions like allergic encephalomyelitis and nerve tissue-based vaccines. Safe with no chance of protein allergy, antibiotic allergy, and bird flu transmission as seen in the chicken and duck animal. In case of shelf life vaccine, as it is lyophilized, so shelf life around 3 years, that complies with the children in-house, that is WHO specifications are there. Thank you.
Paul Rattler. Thank you, sir. Thank you very much.
Hope I have covered it
You have
with minimum time.
You have justified the crowd. Thank you for that. Just wait for 1 minute. This is time for thanking all of you, thanking all the colleagues, pediatricians, respected seniors who have stayed here for our topics on neuroradiology. This CME is sponsored by Bharat Biotech, so I request the representatives from Bharat Biotech to come up. Dr. Nakate sir will felicitate them as they have given academic grant to this session. I thank from Solapur IIP and request both of them come up and thank you very much. I thank Dr. Ghate sir for coming for the CME and I also thank the senior pediatrician Dr. Vaidya sir, Sakhi sir for always giving energy to my CMEs. As today is a little bit present is little bit on lower side, I assure Dr. Ghate sir that we will definitely have higher numbers in upcoming CME. But for the sake of the things, I would like to tell, this is the minimum strength we had today actually. Since beginning from January, minimum 55-60 students or pediatricians are there. 35 registrations were there for today's CME. Still outside there are 45 registrations as MMC points are there. I thank you for that. I once again thank all the speakers, Dr. Hire Kirur sir, Dr. Sri Ganesh Patil sir, Dr. Sahil Savaskar, Dr. Nakate sir. Thank you very much again. Thank you so much. We will be meeting next month only because I have stopped these 2 CMEs for this month. Now we will be meeting in the Mahapedicritic. Thank you.